Hello, good evening, everyone. I hope my voice is clear. So let's start. Tonight is just a very simple sharing on the short cases, basically just cardio, neuro, respi, and abdo. And we'll make it a more simplified manner. And there's also a previous recording of something similar, but in more detail that I think anyone can go through at their own timing. But tonight is mainly about a very simple approach. Okay, we will start. So I will just go by the MRCP format. I understand that some who are going for master exam, the the station may be different in terms of the arrangement. But generally, I think it's also about 6 minutes and also 4 minutes or even longer. Okay, so if I follow back the MRCP 2023 format, the station one will be RESPI followed by com skill followed by respi, and then station 3 is cardio neuro, and then station 4 is com skill followed by abdo. So we'll start with respi now. You can see that generally we need to aim almost perfect marks in all the component in order for us to pass the exam. This I will not go through again. So general tips is actually we should really remain calm and then tell ourselves that we are here to pass the exam. Okay, and before we do anything, when the bells ring or when the time start, we should really greet both examiners as well as the patient, and we should try to express our friendliness to them. And but having said that, we just focus ourselves to the patient. Okay, and we bear in mind that before we start any station, we should look at the stem. Usually they will have a stem, a short stem that may actually help us. And the next thing is remember the wiper. We have to wash our hand first before we do anything, and then introduce ourselves, position the patient, adequate exposure, and then surrounding, observe the surrounding. Basically meaning we are kind of like standing at the end of the bed, looking at the surrounding, and also making sure that our exposure is adequate. And always ask for pain, be gentle before we begin. And we should end our examination to finish by 5 to 6 minutes. It depends on whether it's for MRCP is 5 minutes plus before so-called the last 1 minute, or for master is going to be different, right? It'll be longer. So regardless how, after we finish our examination, we should try to make ourselves cover back some clothes of the patient, especially the exposed area, and offer thanks to the patient. As well as we should wash our hand, and then we face to the examiner and never look back at the patient anymore while we present the findings. So at this point of time, it's also important for us to remain good eye contact with the both examiner in each station. Okay, and then we should always mention that we want to complete examination by performing this and that. Okay, we will go through. So let's start with respiratory system. Sorry, there's a lot of people coming in slowly. So in terms of the respiratory system, there's just a few tips that I feel is useful. First is the peripheral screening. In respiratory system, when we stand at the end of the bed, before we ask patient to do anything, when we observe the surrounding, the first thing we should ask the patient to cough and see whether patient have a very copious, productive, or even chesty cough, or patient cough is like more like dry cough. This cough nature can actually help us to differentiate, like you're dealing more with the fibrosis or you're dealing more with bronchiectasis. Only then you check the clubbing, and then that would give clue to fibrosis or bronchiectasis again, or even some suppurative lung disease like TB or even lung abscess, which we cannot usually. And look at the general build of the patient. Sometimes it may help as well, especially when patient is very caucasic. You know that this is either lung cancer or TB most of the time. And sometimes when you look at the patient chest, you may find, or even at the back, sometimes they actually patch the fentanyl at the back. It's possible. So sometimes if you found the fentanyl patch, then you know that most likely this is lung cancer. Okay, it's also quite useful. And if patient have any tattoo marks or even injection marks, then that will also tell you that can this be you're dealing more with TB patient. Okay, and another clue is actually to look at the general facial appearance of the patient. Sometimes if you realize that patient looks like muffanoid in a respiratory station, you may want to suspect that you're probably dealing with some form of muffin with bulectomy, with some scar, chest tubes, and because of the recurrent pneumothorax. Okay, and the next thing about respi is actually do not miss the trachea, because it's very important, very, very important. Examiner will actually calibrate whether you fail or pass if you don't examine the trachea. So trachea is very important to tell whether it's central or deviated. And generally when we go for exam, we should do anterior and posterior. We should not just focus on the back. I know everyone got different idea, different examiner or different tutor teach differently, but like I still follow the traditional way I was being taught since medical school until MRCP, until Prof. Tan Hui also told me the same thing as well, in which we should train ourselves to complete the anterior chest examination by 2 minutes. That includes the standing at the bed, asking patient to cough, checking the fingers, check for CO2 retention, check for any scars, proceeding to the head, and then at the same time stop at the neck, okay, and also look for tracheal deviation, and then only inspect for any chest scar, and then only chest expansion, percussion, vocal resonance, as well as the breath sound. So all this should be done in within 2 minutes. We should really train ourselves 2 minutes, and then after that, then we immediately proceed to the back, and we focus just on the back. And the back, you can start off with lymph node examination, or you straight away proceed with the back first. Generally, if me, I will proceed with the back straight. After I've examined everything finished already in terms of the posterior chest, then I will only check the lymph node. Okay, usually the time is enough. And bear in mind that certain cases is not stable enough to come out in the exam. In order to find those stable patients, usually they will be very stable to be examined multiple times by candidate. So those like massive pleural effusion, symptomatic one, or pneumothorax without any foul or scar is unlikely to come out in exam. It's not fair. And sometimes when we think about a certain scenario that there's a lot of mixing of sign. For example, you find collapse consolidation, you find corpse crabs, you got some bronchial breathing, everything is like mixed up together. You don't know what is it. Probably you should put your bet on the TB because it's one of the commonest cases that can come out in exam. It can present in various ways. Okay, so this is how I put in my mind when I approach to a respiratory station. So first of all, I want to ask when I examine the patient anterior chest, I should be able to tell that whether patient's chest expansion is symmetrical or asymmetrical. And I mean, this also includes whether the trachea is deviated or central. Second thing is whether patient got any thoracotomy scar. Let's say this is a symmetrical chest expansion without any scar at all, then most likely you're dealing with either bronchiectasis, fibrosis, or obstructive airway disease like COPD, which can, I mean, COPD can commonly come out in exam. The only finding is perhaps hyperinflation, prolonged expiratory phase with or without bronchi, and that will be it. That will be the sign that can commonly come out in exam. Okay, if let's say there's no scar, and however the chest expansion is asymmetrical, or I should put it that the trachea is actually deviated, not central. So you should really think about collapse consolidation, pleural effusion, or even like tractional bronchiectasis or fibrosis. Okay, so the clue is actually the chest expansion is also, to me, is more useful than sometimes tracheal deviation, unless the chest expansion at the upper zone, in which is quite not, we are not sensitive to detect the chest expansion at the upper zone, and therefore the tracheal deviation will be the more sensitive one. Okay, let's say the chest expansion is symmetrical, but there is a thoracotomy scar. So you are dealing with a few possibilities in which it can be due to bulectomy. Okay, it can be due to middle or lower lobectomy. It can be due to lung transplant, but generally it's unilateral or bilateral, depending on what kind of scar. And it can also be due to peurectomy with decortication, commonly in like lung empyema. So those peurectomy and decortication, if the lung will expand, it will eventually leads to symmetrical chest expansion, but there will be a wart scar or even thoracotomy scar present. Okay, so if let's say it's asymmetrical chest expansion, but there is also a scar, what are the possibility? The commonest station that can come on in exam should be the upper lobectomy and also pneumonectomy. These two tends to be the favorite exam question that will come out in exam. And okay, we're just going to mute. Okay, so another possibility is either whether you are dealing with recurrent purification with multiple chest vein scar, that can also lead to asymmetrical expansion. Or if patient like COPD that underwent a lung volume reduction surgery, most of the time their lung will be actually collapsed. Okay, part of the lung will be collapsed. Okay, so we call selective collapse. So in those patients, usually you will find a thoracotomy scar as well as asymmetrical chest expansion as well. Okay, so in respiratory, there's only 4 possibilities if you want to simplify it. So the possibility would be either you're dealing with CREPS, either you're dealing with reduced breath sound, either you're dealing with scar, or it can be a combination of all this, or you're dealing with normal respiratory examination. Okay, so if you're dealing with crepitation, then mainly you are dealing with the differentiating between bronchiectasis or pulmonary fibrosis. if you're dealing with reduced breath sound, in my in the olden days when I prepare for exam, I only prepare for two, which is pure effusion and collapse consolidation, which tends to present with reduced breath sound. But bear in mind that exam can come out something what we call as pleural thickening or fibrothorax. Exam we also can come up with something like elevated hemidiaphragm. So all these findings can actually present as reduced breath sound as well. Later we'll go through. For scar, we can have lateral thoracotomy, whether it's a low back or pneumonac being the commonest, or it's a wide scar, very triangular shaped kind of scar. For scar station, I also got separate video you all can go through or listen at your own timing. We will not go through those in detail. And bear in mind that there's always a possibility of getting a normal respiratory finding in respiratory station in exam. So sometimes we need to think whether this is COPD or whether we are missing something before we say this is normal. Okay, so let's go to crepitation. So if we go to crepitation, we mainly want to differentiating between bronchitis or pulmonary fibrosis. So that's why the first clue is perhaps I put it in bold because those are the points that can help us to differentiate. So in terms of cough, we know that bronchitis is actually chesty and red, and sometimes it can be copious. That's why we look for sputum mark. But pulmonary fibrosis, most of the time it can be very dry and generally less chesty and generally is minimal. Okay, but this is not hard and fast rule because end stage fibrosis can also become bronchitis as well, the late stage fibrosis. So it's not very helpful. Clubbing can present for both. Sometimes bronchitis don't have a very obvious clubbing. Sometimes may have just a very mild form of clubbing, like for example, loss of angle. And then the next thing is actually the scar. So let's say there is a scar, we should really suspect that whether there is a lobectomy, pneumonectomy, or a possibility of lung transplant. In our country, lung transplant is not a favorite kind of patient because they are very old already. And I think for many years, our center doesn't, in fact, in IGN or even in CVS KL, they seldom do any lung transplant recently, in the recent year. So if you come out, you expect someone old, or someone maybe they import from some overseas people, but it's not common. The only clue is actually whether you want to look for any clamshell scar, or whether you are looking for just a lateral thoracotomy scar with a normal lung finding. Okay, so tracheal deviation, usually bronchiectasis or even fibrosis will be central, unless there is tractional bronchiectasis or tractional fibrosis, then it can be deviated. Chest expansion will be reduced definitely, the affected side, most likely is symmetrically reduced or upper zone or lower zone reduced. And percussion usually is down. So you can see that all these are not helpful. But what is more helpful is actually perhaps the three things. First, I mentioned is a cough. Second is the crepitation. We know that bronchitis cause cramps and it alters with cough. Okay, in pulmonary fibrosis, it should be fine and inspiratory or even pan inspiratory or even early inspiratory. And however, remember that in the late stage pulmonary fibrosis, all the fine crab will become coarse crabs already. They are like turning into bronchitis already. And sometimes they may or may not alter with cough. So it's a bit tricky if you go just by crepitation. If you use fine crabs to be pulmonary fibrosis, coarse crabs to be bronchitis, then you will be surprised that certain patient pulmonary fibrosis is actually very coarse crab. So it's not, again, not very accurate. So what is more accurate to me, in my opinion, is the end inspiration. So when you ask patient to breathe in and breathe out by opening the mouth, when patient breathe in, just observe and listen the amplitude of the breathing just before the patient expire, because at the end inspiration, if it dampens, then it's most likely it's bronchitis, meaning to say it can start like early inspiration or mid inspiratory, but usually towards the end of the inspiration, the amplitude will reduce. The reason is permanent dilatation of airway. The large airway already open, the small one cannot, it's already open in the beginning, and the large airway cannot be opened further. So that's why, and sometimes because of mucosal plugging as well, the end inspiration is definitely going to be reduced more. How about pulmonary fibrosis? Pulmonary fibrosis will remain loud and clear at the end inspiration, loud and persistent. So that will be a very, I would say, a very good clue to actually tell us whether you are dealing with bronchitis or pulmonary fibrosis. So in terms of etiology, just going through a recap, in exam, we just need to know like 3 or 4 causes sometimes, so to actually answer the examiner question. If you're talking about bronchitis, it can be obstructive, what we call as intraluminal, luminal, or extraluminal, or it can be infective, immunodeficiency, autoimmune, syndromic, depending how you memorize it. But generally, this is how I try to make it simple. I usually look for the local causes, which is the obstructive one. Intraluminal can be foreign body, aspiration. Luminal one can be cancer or obstructive airway. Extraluminal can be due to lymph node compression like lymphoma, things like that. Infective TB, ABPA, and childhood infection. Immunodeficiency can be congenital or acquired. CVID is one of the favorite differential diagnoses for bronchitis. Congenital also can include the hypogammaglobulinemia. Acquired will be the RED. Autoimmune can be all the ILD or even the connective tissue related bronchiectasis, including the IBD as well. Syndromic for bronchitis, there's only three, which is the yellow nail, primary serious dyskinesia, and cystic fibrosis. So the only caveat when you examine respiratory system, when you encounter club patient as well as cost capitation, and you're thinking it's bronchitis, make an effort to really listen to the apex beat when you still got time. Okay, because sometimes if you somehow detected a dextrocardia, then you know that your diagnosis is actually primary serious dyskinesia, Carter-Gardner syndrome already. Okay, but it's not a routine to do that. It's just that when you examine, when you still got time, then you want to do extra, then you should go ahead to do, because to feel for apex beat in exam, I usually will not feel for full apex beat. I will usually just anterior chest. After I finish everything, I will just feel for any loud P2. But if I got time, definitely I will feel for apex beat. But most of the time for MRCP level, we are very rushed. But for master, I think we have got more time. And in terms of pulmonary fibrosis, how we remember is upper zone predominant or lower zone predominant, right? So it's the usual thing. Apical, or what we call as SCAT. Basal is a ratio, SCAT ratio. So it can be silicosis, sarcoidosis. I think all this everyone knows already, no need to go through. But this is just how we generally remember. And just bear in mind that apical and basal, in terms of in relation to autoimmune or connective tissue disease, especially the rheumatological condition, all the rheumatological condition is actually belongs to the lower zone predominant fibrosis, abscess, psoriasis, and ankylosing spondylitis. That would be the only caveat. The rest of it, I think everyone knows. Okay. So next thing is when we're dealing with reduced breath sound. Okay, reduced breath sound can be a bit tricky. So this kind of scenario of reduced breath sound, I'm focusing more of reducing breath sound at the lower zone of either side of the lung. Okay, it can come out commonly, and there's also a possibility that there is also some bronchial breathing at the upper zone and reduced breath sound at the lower zone, something like that. But this kind of scenario tends to be quite favored as well, because we know that TB is really a favorite. Okay, so we're dealing with pleural effusion. Let's go through to differentiate between these four, right? We got pleural effusion unilateral, we got pleural thickening, we got collapse consolidation, we got elevated hemidiaphragm. So when we look at the scar, most of the time, pleural effusion may or may not have scar. Pleural thickening also may or may not have scar. Sometimes they do some, pleurodesis or some form of procedure intervention. So you may have a bit of scar, but it's not optional. Collapse consolidation usually don't have any scar, and elevated hemidiaphragm may have scar. Let's say inserted chest tube before, okay, then it may have scar. The next thing is perhaps is useful is to tell whether the trachea is central or deviated. In unilateral pleural effusion, depending on the severity, if it's just a moderate pleural effusion or mild effusion, then you will expect the trachea will not be deviated contralaterally. But let's say it's a very massive or very significant effusion, it may deviate to the contralateral side. For pleural thickening, generally it should be central. However, in those very severe fibrothorax, you got this tractional fibrosis, pull up the lung towards the ipsilateral side. It can present as ipsilateral tracheal deviation. Collapse consolidation is the favored ipsilateral tracheal deviation. Okay, the upper zone when you listen, okay, there's bronchial breathing. At the same time, when you feel for trachea, is actually ipsilaterally deviated to that side, and the breath sound is reduced at the lower zone. Then you know that probably this is collapse consolidation. And how about elevated hemidiaphragm? Most of the time it's just central. Okay, you can see that pleural thickening and elevated hemidiaphragm, usually the trachea is at the central position. When you go by chest expansion and percussion, they are all the same. At the affected site, if ipsilaterally reduced, percussion at that particular site is down. It can be stony down or down. Okay, and breath sound is ipsilaterally also reduced. You can see that breath sound is also not very helpful. Pleural effusion definitely reduced. Collapse consolidation, you will have a special bronchial breathing, which is almost the same nature as you auscultate over your trachea. It's very whole like that. Okay, that means there is a very there is a pause in between the inspiration and expiration, and generally the expiration is actually longer as compared to the vesicular breath sound. And for pleural thickening, usually there's also sometimes may have a bit of craps, but usually it's just reduced breath sound. And elevated hemidiaphragm definitely just reduced breath sound as well. The next thing is a vocal resonance. Vocal resonance is important because in consolidation, that area will be increased. Okay, the rest of it is basically just reduced. Okay, so you can see that it's a bit tricky, right? We know that this kind of scenario can come out very frequently in exam. Patient can have a pleural effusion with some scar, and then this is a recurrent effusion, and that effusion can be complicated or can be simple. Okay, we don't know what is the cause. Or patient can have just a very like hackasic kind of patient, and then maybe got a bit of clubbing, and then when you saw the patient, all the wasting on the muscle is seen, especially at the cervical region. When you check for chest expansion, before you check for chest expansion, you feel for trachea. The trachea is divided at the right side. Chest expansion is also reduced at the right side, upper zone and lower zone. When you auscultate, they may have some bronchial breathing at the upper zone, and the middle zone or lower zone may reduce. Okay, and generally when you go for the remaining finding, is almost the same. So you know that kind of finding is pointed more to collapse consolidation, and you're dealing with some etiology that you need to offer. So this is to me, this is a useful list because it gives you a list of differential diagnosis when you answer the etiology. So for effusion, you can divide it. Usually the commonest is pneumonic effusion or infection related, which is the TB, can be TB pleural or pneumonia effusion or empyema. It can be mitotic, which is what we call as malignant effusion. It can also be autoimmune related, like connective tissue disease, commonest being RA and SLE. And the rare one is the one that I put rare because we won't generally mention about that. But let's say examiner one more, then we will mention like chylothorax, hemothorax. Pulmonary infarct can also present as effusion, drug-induced effusion. Those are very rare. Rare nail syndrome can come out in exam, but you will recognize it on the spot when you see the nail. So, but generally, if urinary effusion, usually we will categorize it as infective, mitotic, or even autoimmune. Usually these three. Pleural thickening can be malignant or benign. If you're talking about benign pleural thickening, you're talking about like pleural TB, pleural empyema, or recurrent pleurisy like multiple infection, or asbestos related lung disease, or like hemothorax, or even like post-pleural disease. Those patients that went for pleural disease, can be heart pleural disease or blood patch pleural disease. They tend to have pleural thickening later on, and they may actually almost same finding as pleural effusion when we auscultate everything. Okay, so the difference is actually you really need to see whether there's any crepitation or not. Usually this kind of pleural thickening, they may have a bit of crepitation. Okay, and the malignant causes of the pleural thickening can include all the pleural cancer or pleural metastasis or even secondary pleural lymphoma, very rare. Okay, collapse consolidation, almost same as the pleural effusion cause. I think in my exam I got a collapse consolidation, very loud bronchial breathing, and then it's a TB. I think the patient have TB lah, because very thin and very cacassic. And the first diagnosis definitely I offer is infective causes, cavitating pneumonia, TB, lung abscess. That is my first differential when the examiner asked me. Then the secondly, I mentioned about consolidation, but it can be mitotic causes, primary or secondary cancer malignancy, can be endobronchial carcinoma causing collapse and consolidation. Also can also be due to lymphoma. Okay, generally certain in order to have collapse consolidation, that mass must be pushing at the airway, causing the airway to collapse. So that's why it must be something huge. Okay, and ischemic one, for example, pulmonary infarct because of the PE is also possible but rare. Another thing is the foreign body aspiration, like those mucosal plugging or even like very huge foreign body, it can cause collapse. Okay, and another possibility is all the extrinsic compression, and also very rare entity called pulmonary alveolar proteinosis. I don't think anyone want to mention about that, but bear in mind, I just remember the simple stuff. This is just others. The reason I put others is probably not very significant to remember. And bear in mind that in exam can come out something what we call as elevated hemidiaphragm, which can present almost the same finding as pleural effusion. So when examiner asks you whether is actually in fact they are almost the same finding, everything is the same. But if you offer a diagnosis of pleural effusion, they may ask you what's the differential diagnosis with this finding. Then you really need to mention all these differential diagnoses. Can it be pleural thickening? Can it be elevated hemidiaphragm? Let's say there's a chest tube and that is also the same finding, reduced breath sound, reduced vocal resonance, percussion is down, trachea is central. So what can be the cause? So let's say there is some scar, then you suspect more like traumatic causes. What are the possibility of traumatic causes? It can be, the commonest is being diaphragmatic paralysis. Like post-MVA, patient have sustained some trauma, went in for surgery, putting a chest tube, pneumothorax, things like that. Then after everything recovered, the diaphragm become paralyzed, or even have injury to the phrenic nerve, and those actually cause elevated hemidiaphragm. Okay, But it does not cause the trachea to be deviated because the lung is not collapsed. It's just the diaphragm that is not moving. Okay, so another possibility is actually atraumatic, meaning most of the time they don't have scar. What are the possibility? So atraumatic tends to be a bit tricky because you need to suspect some form of congenital lung disease. Okay, congenital lung disease meaning we are talking about like pulmonary hyperplasia of the newborn. When they are very young, they already got some congenital maldevelopment of the lung, and when they grow older, they compensate quite well. But the only remnant finding is perhaps the elevated hemidiaphragm. Or it can be due to diaphragmatic eventuation, diaphragmatic hernia, or abdominal malignancy pushing up the the lung, or it can be due to subdiaphragmatic mass or even like collection, which is rare. But the most important thing is always offer a differential diagnosis of elevated hemidiaphragm if you are dealing with pure effusion, because you can see the finding is the same. It's just that you really need to tell whether this is more to effusion or elevated hemidiaphragm, depending on what kind of stem that the examiner is hinting. Okay, so this will be the outline for reduced breath sound. Next is a scar. This is also available in my notes. Scar basically, it can be a few possibilities. It can be small scar, which is a chest drain or chest tube scar. It can be due to Watt's scar, the triangle tripod kind of shaped scar, in which one of the scar, the larger one is the instrumentation port. The other two is just for the one is for scope, another one is for maneuver. Okay, and what are the possibility of the Watts when you see the Watt surgery, Watt scar? So you should start from the smallest to the largest. It can be due to the biopsy of the lung, can be due to ridge resection, segmentectomy, decortication, bulectomy, then followed by lobectomy or purectomy. You can see a lobectomy is possible be done using the Watts approach. Okay, when you're talking about unilateral thoracotomy, then there's also a few possibility. You should start from the smallest to the largest as well. It can be due to the decortication. It can be due to bulectomy, lobac or pneumonic. That's why it's important also for us to differentiate whether this is a lobac and pneumonic. Okay, I think everyone knows how to differentiate it. Generally, lobectomy, if it's a middle or lower zone, they may have almost near normal finding. Trachea is central. The breath sound can be reduced slightly or it can be just normal as well when the lung will expand. But for upper lobectomy, definitely the trachea will be deviated to the ipsilateral side and the breath sound may be normal or may be reduced as well. But pneumonectomy, definitely the trachea is deviated to the ipsilateral side and there will be absent breath sound. You won't hear any breath sound at all. Okay, the lung is removed. Okay, so what are the other possibility of unilateral thoracotomy? Can be due to lung volume reduction, open surgery, purectomy, those like recurrent pneumothorax, no other choice already. And then those another rarer one is actually the extrapleural pneumonectomy. Basically, it's very rare. I think generally we somewhere stop between these four. Okay. The next thing is the bilateral thoracotomy. This is something we need to watch out for because it can come out in exam if it's a lung transplant. Generally, we should check the breast fold, especially the inframammary breast fold, to look for any scar to avoid us missing a clamshell incision. Okay. Another possibility of the scar is those very rare and very now it's very modern already. Those days, those scar is quite common. Anterior mediastomy scar, like Chamberlain procedure, is for the lymph node removal surgery. Or sometimes nowadays more common is we always refer IR for CT guided lung biopsy or even form of other biopsy. You will see a lot of this small scar, transverse mini thoracotomy kind of scar is actually the CT guided biopsy scar. Or sometimes can be due to cardiothoracic mini operation, mini biopsy scar is also possible. If it's a supraclavicular scar, those are also very old already. I don't think any TB patient underwent any form of this surgery anymore. It's like a phrenic nerve crash. Usually you will see all the supraclavicular will be deformed, and posterior thoracotomy, the whole rib cage, I mean, a few ribs are absent. The patient will generally will be scoliotic and will be empty a bit. When you press, it's like very soft. But generally, we don't see that kind of patient anymore in our exam. Okay, so the last possibility is actually the normal respiratory examination. So when you encounter a very normal case, you should tell yourself whether you're dealing with obstructive airway disease like COPD or asthma, in which the sign you are expected to find is just increased AP diameter, tracheal tap, prolonged expiratory phase. Or it can be due to a collapse that was missed, in which your tracheal, when you feel for tracheal may not be sensitive enough, you actually miss it. Actually, the trachea is deviated to one side instead of central. So it is possible. And the Third possibility is whether there is consolidation, because sometimes the consolidation does not cause tracheal deviation if there's no collapse. So it's also important that whether you really listen hard for any bronchial breathing, okay, or any increase in vocal resonance. And the fourth possibility is whether you are missing any scar. Sometimes the scar can be very faint, and especially if patient can be too dark or too fair, the skin, the line is just simply not easy to see. So if let's say there's a lower or middle lobectomy, you may miss it. Or even as a clamshell, you may miss it if you didn't examine the breast properly. Okay, so that will be this kind of four possibility. Okay, so usually yeah, someone texted something, right? Okay, never mind. So usually after we complete our examination, we should offer all this. We should complete examination by checking observation, bedside peak flow, sputum port. And if you're suspecting something like to look for etiology, you should offer to check for relevant system. Okay. And you should, for master perhaps it's so important to ask relevant history in terms of occupation of drug. But for MRCP, we generally don't actually mention about history. We're just focusing on the examination and what are the things you want to check. And the next thing is perhaps we should make ourselves very structured when we present our finding, and then examiner asks us how to investigate and how to manage. We should have our own template to diagnose or to actually stage the severity. You should order what, for example, X-ray, lung function test, blood gas, HRCT, or even like diagnostic tapping. Those kind of useful investigation, or even lung biopsy. Okay, so to actually identify the etiology as well as the complication, you should proceed with, for example, sputum, echo, right heart, CCT, specific CTT screening, even serum A's or things like that. But you can see that generally, I mean, everyone have own approach. You don't have to follow this kind of approach. Sometimes if you want to start with fluid count, you start, and then after finish with blood, you go to radiology, and then after that you go to tissue, then you go to others, is also okay. But to me, for MRCP level, if you present like that, it seems more professional and it's more organized, and you also got time, a bit more time to think. But there's no right or wrong way. You can do whatever way you want as long as your message get carried. And the management generally, you should always focusing on non-pharmaco, pharmaco, and specific. So non-pharmaco will be multidisciplinary approach, focusing on patient education and counseling, stop smoking, avoid the triggers or the drugs, pulmonary rehabilitation, oxygen therapy if required, dietitian, and vaccination. Always remember on the vaccination, okay? Especially for need to know the pneumococcal vaccine, what is the latest guideline. Influenza is still annually, pneumococcal is no longer 5-yearly. Please don't mention 5-yearly pneumococcal, examiner is going to kill us. And the COVID vaccine is also sometimes worth to mention. For COPD, then there's a role to mention about mention about varicella zoster vaccine and all those. Okay, pharmacologically, we should also mention that we want to optimize the underlying condition. For example, like bronchitis, you want to mention about mucolytic expectorant. And for example, like obstructive airway disease, you can mention about some bronchodilators. And for example, antibiotics, short course or even long course as an anti-inflammatory purpose, not to kill the any colonization, but just for anti-inflammatory purpose, especially in bronchiectasis, or even consider roles like steroid if it's ILD. Bear in mind that ILD got two different spectrum. If you're talking about inflammatory subtype, okay, then you are talking about steroid usage. If you're talking about fibrotic subtype, then you are talking about anti-fibrotic use. So there is something called as NSIP and there's something called UIP. NSIP is a spectrum of which is quite near the organizing pneumonia. It's an inflammatory subtype, okay, in which you can try with steroid. But as the patient become UIP subtype, it's already fibrotic. There's no role to give any steroid anymore. The focus will be the anti-fibrotic, okay? And the rest will be the targeted therapy if it's indicated. Like, for example, if you cannot encounter any cystic fibrosis, you want to mention the new therapy, CFTR modulator, combination therapy, like lung cancer, you want to mention targeted chemo, radio, molecular study, all those things. And then like surgical, want to mention about low back or pneumonic if it's feasible for surgery, or even lung transplant. And sometimes if it's a late stages, you want to mention about advanced care planning. Those are just a very simple one. I can see that there's two people raising the hand. Is there any question you want to ask me before I proceed? Aina and Elaine. Okay, so Yong Chi Yu is asking me about pneumococcal vaccine. Okay, so nowadays the guideline is quite straightforward. So in Malaysia, like I'm talking about Malaysia and not talking about overseas. Overseas got PCV 12, PCV 20, PCV everything got different serotype. Okay, I'm talking about Malaysia, we only got PCV 13 and PCV 23. okay, or what we call as PPV 23. We got PCV, meaning is actually uh, is a conjugate vaccine, okay, and PPV is actually a polysaccharide vaccine, okay. So if you're talking about PCV 13, so the guideline says like that. So not everyone needs to go for pneumococcal vaccine, but those patients on have a chronic, so-called chronic lung diseases, in which the asthma, good control asthma is not considered, but generally the rest of it is considered. So like COPD or even like wholly controlled asthma, or even like lung cancer also, or even bronchial fibrosis, occupational lung disease, all are included. And generally, what is the guideline says? The guideline states that less than 60 years old, you should go for the first jab, which is the PCV 13. Okay. And then PCV 13, 1 year later, you should go for PPV 23. Okay. This is less than 60 years old. By the time patient reach 60 years old, then you can jab again, repeat the same thing, in which you can either, there's two options. You can either give PPV 23, then you can consider as complete vaccination for the entire lifetime for the patient. That means total 3 doses in the entire lifetime. Or you can give another dose of PCV 13, followed by 1 year later PPV 23. So total 4 doses. Generally, you can see that based on this regime, right? Generally, a person live long enough. I mean, the longest, like you reaching 90 years old, even 100 years old, also generally only receive about 3 to 4 jabs of pneumococcal vaccine. No longer like every 5 years you have to jab once. No, that was the old traditional teaching. Okay, so what happened is if you inject the patient with PPV 23 first, you cannot wait for 1 year before you inject PCV 13, because PPV the effect lasts longer. So if let's say the first less than 60 years old, you accidentally give the patient PPV 23. So next thing is actually you have to wait 5 years until you can jab the patient with PCV 13 to complete that so-called less than 60 years old pneumococcal coverage. And then after that, after more than 60 years old, same thing repeat. It's the same, okay? But there's only one caveat which I mentioned for this rule, is that patient with immunocompromised status, for example, end-stage renal failure, for example, patient on high-dose steroid or immunosuppression, or patient with RED, which is commonly seen in our ID clinic. So this kind of patient, after you give PCV 13, you don't need to wait for 1 year in order to jab for PPV 23. You only need to wait for 8 weeks, and then after that you can jab for PPV 23. That is the guideline. But let's say you already jab PPV 23. Unfortunately, there's no way you have to wait for another 8 weeks. Only then you jab for PCV 13, because once you jab PPV 23, the guideline says that remains the same. You still need to wait for 5 years. Okay, that will be the guideline. Okay, so this is how the pneumococcal vaccine works. Okay, generally this is the timeline. Okay, so okay, next is actually regarding abdo. No question, I will proceed with abdo first. If anyone have any questions, just post and we'll answer. So for abdo, perhaps the important thing for abdo is to really screen for peripheral sign. And then we should really focusing, this is just a general run through. Periphery, you are standing at the end of the bed, you're exposing the patient abdomen. But generally, the abdomen screening when you're standing end of the bed is to look for any stigmata of chronic or end-stage renal disease. You should ask the patient to expose both of the hand properly when you see, so that you don't want to miss any hidden fistula or any hidden fistula scar. Okay, so those are the one that you don't want to miss. So periphery, you should screen for the AVF or scar, because that will suggest it's a renal abdomen. Okay, and I think then following, you check the finger, look for carving and stigmata of CLD, check the head to look for anemia and jaundice, check the mouth to look for any dental hygiene, or even T mouth occlusion in thalassemia, or even gum hypertrophy in cyclosporine. Suddenly everyone will realize that the mouth is actually quite important, not just to check about the whether any poor dentition or not. It's mainly to check whether patient got any thalasssemic feature, or patient can have any suffer from any immunosuppression complication like cyclosporine gum hypertrophy. And don't forget to check the neck, especially to look for any scar like parathyroidectomy scar, which will suggest the mineral bone disease. And then you go to the chest and axilla again to look for any stigmata or chronic liver disease. Generally, you just want to look for any spider nevi, and then ask patient to actually put their hands over their hips, and then open up their axilla and look for any hair loss and gynecomastia. At the same time, look for any scar, if let's say there is. Then after that, you should, at this point of time, ask patient to lie flat, because generally sometimes the patient is like 45 degrees on the bed. So periphery, you still proceed. You don't need to lie the patient flat when you check the periphery. Unless you really worry that you'll forget, you want to lie the patient flat to begin with, it's okay. But let's say patient is on 45 degree, you don't want to catch out, just examine the peripheral is fine. But when you reach the abdo, you should really make sure the bed is flat and you should get a chair. You by right, we should not kneel down. It's not very professional. We should get a chair, ask for a chair from the examiner. That definitely give you a chair. Okay, so we'll sit on the chair and examine the patient abdomen, inspect, palpate, beneath or ninth quadrant, liver and spleen, and then percuss ballot, and remember to auscultate. The reason why I put it underlined for auscultate is because sometimes when you do abdomen, you fit here and there, you percuss everything, then you will forget to ballot and auscultate. That happens to everyone because you already do everything. You thought it's like, okay, the next is the lymph node only. But you're actually missing to auscultate the abdo. It's very important to always remember that after you are finishing to ballot the kidney, make sure you auscultate. Make sure to auscultate. After that, this is my approach. After that, I will ask patient to sit up for me, and then I will start to examine lymph node at the back, from the back approach. Posterior approach, I will check the lymph node. And then I will, at the same time, the reason I'm doing asking patient to sit up to check the lymph node is also because I want to look at the patient back. A few things I want to look at is the lower back. I want to check for any scar, any nephrectomy scar, any BMAT scar. Second thing is the upper back. I want to look for any other stigmata of chronic liver disease. You'll be surprised that sometimes the tattoo marks or even certain spider nevi only appear at the back, which the anterior you cannot find any very obvious stigmata of chronic liver disease. That brings to the question of it's also important for us to check the back. Okay, so for thalassemia, something special about thalassemia is because thalassemia is very straightforward. So examiner tends to have more expectation on us. For thalassemia cases, you cannot just check the abdomen. You should offer to or even attempt to check to really auscultate the especially the upper and the lower left sternal edge to look for any loud P2 or even any tricuspid regurgitation, which may suggest cardiomyopathy because of the secondary hemosiderosis in thalassemia. Okay, so only in thalassemia you need to check cardio. The rest doesn't really need that. Then after that, you check the pededema and you offer thanks to the patient. You want to close the patient, the exposure, and then wash your hand and then add an examination by asking you want to do what. That would be I would say this is a better approach because abdo generally you will definitely have enough time. Okay, if you practice enough for MRCP, usually by 5 minutes you should finish everything, and if you slow down a bit your pace, definitely is more than enough. Okay, so next thing is how we divide abdo is actually I like to divide the abdo into renal and non-renal. Basically, it's because in renal abdomen, there's certain things that we need to find and there's certain template that we need to present. It's a bit different than the conventional non-renal cases. It can be hepatobiliary or hemato, and those generally we can present like from the peripheral, then from the central, and then offer a provisional diagnosis and followed by the discussion. But for renal, we tend to go by a template because renal is easier when you present it as a template. Because patient can have multiple scar, can have 10 scar, can have 9 scar. If you're going to present all those things in peripheral signs, then examiner also will be bored. And then we haven't even managed to reach the main point, then the time may be up already. So we don't want to risk that to happen. So renal, I think to me, is a safe approach to really present with a specific template. But generally for other cases, we have to use back the conventional method, like how we present like in the medical student time. For renal abdomen, you are talking about 3 possibilities mainly. You're talking about whether patient is a scenario of RRT or what we call nowadays is called kidney replacement therapy, KRT. Okay, it can be due to HDPD or transplant, or can be both, can be all, it can be a mixture of all these, but basically it revolves around the RRT. The second possibility is the adult polycystic kidney disease, which is so common. It can come out in exam most of the time. And bear in mind all the possible variation that can come out for ADPKD, because they may remove one kidney, they may remove both kidney and transplant one kidney, and they may remove both kidney or even transplant both kidney. So there's a lot of possibility that can come out. Or sometimes they also remove the part of the liver, or sometimes they also remove part of the spleen. Things like that can also happen because got polycystic liver and polycystic spleen also. So all these things is also a possibility. So can be tricky, and sometimes they may combine with RRT. Patient adult polycystic kidney may have RRT as well on RRT. So this makes the renal abdomen can be a bit more challenging. And the third possibility is generally a bit rare, which can come out, which is a syndromic patient. For example, von Hippel-Lindau patient. I think von Hippel-Lindau is not common in Malaysia because in UK it can come out with a bilateral nephrectomy, with a renal transplant in the front, that will suggest that this can be due to bilateral renal cell carcinoma that was removed. And patient may, because of this finding, you need to suspect that whether the patient etiology is a syndromic patient, okay? Like for example, tuberous sclerosis, neurofibromatosis, or even like in this case is the von Hippel-Lindau syndrome, okay? So this is the renal. Non-renal can be hepato or hemato, and generally it actually revolves between whether the spleen is enlarged, whether the liver is enlarged, or whether both are enlarged. Okay, if if usually they will have something that is enlarged lah. Unless nothing is enlarged, then it can still be like chronic liver disease. Or the other themes is other than chronic liver disease, the chronic hemolytic disease like thalassemia, and there's some other chronic hemolytic disorder like for example, chronic IHA or even like hereditary spherocytosis, those are the one that also can come out in exam because they are very stable. Okay, and certainly myeloproliferative or lymphoproliferative disease can come out in exam as well. For example, elderly with a very huge spleen, you know that this is myelofibrosis. Okay, you want to offer the like all those thalassemia, all those things very rare, or malaria can, but please bear in mind that all this kind of spectrum you should offer myelofibrosis first, and then followed by other form of like you can also mention about this myeloproliferative neoplasm, which include polycythemia vera, or it can also include chronic myeloid leukemia, can also include this essential thrombocytosis or even this myelofibrosis. Okay, lymphoma, also called lymphoproliferative disease, usually they may have lymph node palpable. Either usually can be quite huge or sometimes can be very minor. So therefore, it's also important for us to, if we don't have time, we should offer to check for inguinal lymph node. But for abdomen, we are expected to check for cervical lymph node. So that is the expected one. Okay. So other possibility can come out in exam is just the ascites alone. There's no other sign but ascites. So they will talk through what are the possible differential diagnosis of ascites and how to work out. And another possibility is a liver transplant, which is just a scar. Basically, it can be like modified Makuchi incision. It can be rooftop chevron scar. But generally, they may be just like a scar, nothing else. No palpable liver, no spleen, no chronic stigmata or liver disease, just one scar. So you need to offer a differential diagnosis. Other than liver transplant, can it be due to like hepatobiliary surgery? You're talking about cholecystectomy. You're talking about removal of gallbladder empyema in the past. All those like hepatectomy, all this possibility. Okay, and another possibility is the IBD that can come up, in which the patient will usually have some stoma, and usually will have some midline laparotomy scar. Those are the patient that underwent surgery and then put on stoma, and then usually they may have some, also usually very difficult to appreciate, but they will be appear a bit pale, and they may or may not have liver transplant. Certainly, if let's say got stoma bag with the liver transplant scar, you know that this is a PBC associated with UC, but that is the like a very classic exam case, which is not commonly found in our setting. But bear in mind that if you got stoma bag in the abdo, you should think of IBD. And suprapubic mass can come out as well. It happened to me when I when I go for my first attempt. I don't know why they had to push a gynae lady with a suprapubic mass, very firm, very I cannot feel the lower border, and basically I think it's an ovarian or even uterine malignancy. And they ask about differential diagnosis. This is also a possibility if they are short of case and they just want to test your knowledge. So in this kind of station, you need to offer a few differential, can be adenomyosarcoma or adenoma or fibroid, a very huge fibroid, or even the ovarian less likely because it's a peripheral. You're talking about more like uterine pathology. It can also be bladder origin. It can also be something like TB gut, which is a bit rare. And don't forget to screen for pregnancy in this kind of scenario with a suprapubic mass. Okay, so that will be the approach. So for renal, I tend to present in this approach. I mean, you can present from the beginning to the end is also okay, depending on how much time you have. If you think your presentation is too long, perhaps you should do a very quick summary by mentioning about that. So let's say I have a patient underwent a right renal transplant and got a non-functioning AVF. There's only one scar, and there is a midline laparotomy scar with a like some Tankoff removal form of surgery. There was the transverse incision over the para-umbilical region, and there's also a parathyroidectomy scar. There may be also some form of scar at the deltoid or even at the bicep. So how do I present this kind of patient? So I would say that, sir, my diagnosis for this patient is end-stage renal disease on renal replacement therapy. The active mode of renal replacement therapy would be a right renal transplant, evidenced by the right Rutherford Morrison scar, and which there is no buried hurt, and there's no tender on palpation over the transplanted kidney. However, in terms of the past mode of RRT, I can appreciate that there is a non-functioning, for example, left AVF. At the same time, there's multiple, for example, neck scar suggestive of previous central line insertion, or even previous IGC insertion. You want to mention that is fine. Or there's also a midline laparotomy scar with a transverse para-umbilical scar, which may suggest a previous Pankow surgery, previous evidence of peritoneal dialysis. And in terms of complication, uh, in terms of end-stage, patient have no evidence of conjunctival pallor to suggest renal anemia. Patient, however, he or she has a paratectomy scar with the evidence of autoimplantation to suggest mineral bone disease. Sometimes may have some digital osteodystrophy as well. And in terms of complication from dialysis, let's say patients on dialysis or complication for RRT, patient is euvolemic, patient is no evidence of uremia, and there is no evidence of infection. Okay. Sometimes patient like liver transplant, like kidney transplant patient, they push for exam. Patient may have some UTI. Patient got one antibiotic like actually hanging at the side of the bed. Then you know that the antibiotic with that renal transplant, then you know that there may be some form of complication for infection. Okay, so other complication for immunosuppression will be patient does not appear Cushingoid. There's no gum hypertrophy, hypertrichosis, or even fine tremor or alopecia to suggest carcinoid toxicity. There's also no skin lesion to actually suggest any malignancy. This HSM, I cannot remember what I put already, but basically, let's say there is a hepatosplenomegaly. I think HSM is a hepatosplenomegaly. Let's say there is a hepatosplenomegaly in a renal transplant patient, or even, yeah, mainly it's a renal transplant patient. You need to suspect, can this be post-transplant lymphoproliferative disorder? Okay, these are the things that you need to make sure you mention that. Okay, then you may want to mention, like, additionally, I also find that the patient have nephrectomy scar at the back, suggestive of previous removal of the kidney. And the etiology for this patient will offer commonest being, we know that diabetic, 60% is diabetic, 20% is hypertensive, and then remaining 5 to 10% is about GN and adult polycystic kidney disease, and remaining 1 or 3% is about drug, which is like the commonest being the analgesic nephropathy. The rest is the autoimmune, post-renal, a bit rare. But you want to go by this template because it's easy for you to present all the findings together. You don't have to go all the way and mention about all those non-relevant and normal sign. Instead, you can just give this kind of summary and you can just score. Okay, so this is what I usually do for my renal station. But other than that, the non-renal one, I will still go by conventional method. So this is something extra about ADPKD and SCAR. The reason why I want to emphasize is that we need to know how is the possibility ADPKD can come out in exam. It can come out as a bilateral kidney, very huge until it nears the liver and the spleen border. The common pitfall will definitely be when you are too nervous, you present this as hepatosplenomegaly, which is going to be a straight fail. Okay, so bear in mind that if ADPKD, you really need to feel for the lower margin and the upper margin. You should be able to feel the upper margin. Sometimes the patient adult polycystic kidney, they have polycystic liver as well on top of bilateral kidney. So the right kidney and the liver the right kidney and the liver will kind of like blend together. But you generally, when you feel in deep palpation, you should able to feel that it's a margin one. Usually there will be a margin. Okay, so the next thing is actually ADPKD can present a scar. Okay, it can be one nephrectomy scar or two nephrectomy scar. It can be anterior approach or posterior approach, and it can also be ADPKD on top of Rutherford-Morrison scar on the opposite side. Okay, so you need to make sure that you are anticipating that you can see any scar as well. And at the same time, ADPKD not just enough to stop at the level of kidney. So if you know that this is ADPKD, you should check for more things. You should check for hepatosplenomegaly, as the reason we mentioned just now. You should offer to check for the eye, mainly to do a simple H test and check the patient eye in terms of pupil and H test basically, just to look out whether there's any surgical third nerve palsy as well as any lateral rectus palsy to suggest aneurysm. And you should check the eye, in which you most likely will already check when you do a peripheral examination to look for any evidence of anemia, to mention that. And the additional thing is to check for the cardio. You should listen quickly at the mitral region to look for any evidence of late systolic murmur or pan systolic murmur to suggest MVP or MR. this will be considered complete for adult polycystic kidney disease. Okay, remember that AD-BKD, the expectation is actually more. We need to really do more as well. And if you're dealing with a station of scar per se, okay, that what are the possibilities? It can be bilateral nephrectomy, like I mentioned. If bilateral nephrectomy, you need to think about why both kidney must be removed instead of just one kidney. So you should think of AD-BKD because it's too huge, cannot occupy the whole abdomen. Peritoneal space is occupied by two kidney. Therefore, you need to remove, or else patient will be constipated. Bowel cannot expand also. So it's possible. And what are the possibility like leads to renal cell carcinoma, especially one hyperlindal or bilateral renal cell carcinoma because of other reason, other syndrome, or it can be due to recalcitrant UTI, very, very refractory, unable to treat, multiple infection, or there is evidence of obstructive uropathy, both sides cannot salvage already, the kidney gone already, therefore you need to remove it. Or it can be due to, we call it resistant hypertension cases, we need to do a nephrectomy in order to remove the kidney. Okay, so I think it's hardly done, but these are the possibilities that you want to offer when you saw a bilateral nephrectomy scar. And what other scar is the Rutherford Morrison is very easy, but you just need to know that we don't generally auscultate on top of that scar to look for any renal bruit. Okay, we have to auscultate at the medial and the lower aspect of the scar because that is usually where the transplanted kidney will be situated, not immediately below or beneath the scar. So we want to see whether the kidney have any bruit to suggest stenosis, and at the same time any tenderness to suggest graft failure. Okay, the next thing is actually the midline or midline laparotomy scar. So when you encounter a midline or paramedian laparotomy, you need to think of few possibility. Can it be due to Tankoff catheter removal to suggest previous PD? Can this be anterior approach of nephrectomy? Or can this be simultaneous pancreas kidney transplant with a contralateral transplant scar usually? So for SPK, basically not available in Malaysia, but who knows that they suddenly got UK people come here, then got this finding, they invite for exam. But generally, it's more common in UK. If you go for exam, you need to know this SPK if you go for exam in UK. Okay. So next thing is bilateral kidney. So this is just a good thing that we should go through. Basically, we need to know that when you are dealing with bilateral kidney, what are the possibility? It can be ADPKD, one hyperlindal, tuberous sclerosis, complex diabetic nephropathy causing both kidney are actually hypertrophic, or can be due to amyloidosis, or bilateral RCC or bilateral obstructive uropathy. Down the list is a bit more rare already, right? And then how about unilateral bilateral kidney? Always good to have this list in our mind because we don't want to be a surprise question when examiner asks and we are stuck. These are all like no surprise question. It's something that we expected to know. Okay. So hydronephrosis like unilateral or pyelonephrosis or perirenal hematoma post biopsy or like ADPKD with asymmetrical enlargement or post contralateral nephrectomy, or can be just unilateral RCC, or can be contralateral nephrectomy with renal hypertrophy at that contralateral side. Okay, it's also possible. So these are the possibility. So generally for renal, when you want to investigate and manage, it go back to the same thing. I would always use this approach because I feel it's easier. I would to know that whether this is to actually stage the severity, I will take a RP, renal function, and VBG and UFAM and quantify the protein. Don't know the etiology, I will screen for HbA1c, hepatitis screening. All those things we are very good to mention. I don't think anyone have any problem. Just develop your own template. And complication, mainly you want to talk about anemia, mineral bone disease, and also the cardiovascular part, because we know that it associated with higher mortality of cardiovascular death. Okay, so management, again, non-pharmaco first, followed by pharmaco and surgical. Non-pharmaco, important to mention about avoiding the nephrotoxic drug, fluid control, dietitian for all the low potassium salt and also the phosphate diet. Okay, protein diet, you need to know the cutoff, pre-dialysis and dialysis. One is actually before dialysis, you want to reduce the protein. After patient on dialysis, by right, you need to give a bit more protein. Okay, so pharmacologically, there is also we need to optimize the sugar, blood pressure, cardiovascular risk, anemia, all those things. I think no need to mention. Everyone also know. Surgical one, basically you want to mention about like all those procedure and like type 1 DN you can offer SPK, and mineral bone disease generally is just I mean this is all self-explanatory. Next thing is the so-called hepatobiliary. So I listed out this chart is because those that have my notes, you will see that this chart is pasted on the first or second page of the short cases, because to me it's always important to have our own template when we want to offer the etiology. The way I arrange it is that I will go by the commonest causes, and then I will mention that at the top three. That means this list will shuffle. It's not always in this order, but generally for hepatomegaly isolated, I will give this few differential diagnosis, in which it can be alcoholic liver. If it's mitotic, also called toxic, is the alcoholic liver disease or HCC. Okay, it can be due to infective like hepatitis, can be due to liver abscess. Inflammatory can be due to these three conditions. Infiltrative, it can be due to metabolic related like MAFLD, like fatty liver, can be due to hemochromatosis or Wilson. Vascular can be due to right heart failure with tricuspid regurg, or can be due to constructive pericarditis or thrombosis, like Bukhari or portal vein thrombosis. And the rare one, sometimes I won't even mention, but sometimes if it's relevant, like for example, if examiner asks you everything also negative, then perhaps you should offer something like cryptogenic liver disease. Okay. Splenomegaly isolated, again, the same thing. I will go by mitotic, infective, inflammatory, infiltrative, vascular, and others. But generally, like I mentioned, the priority will depending on what physical sign I find from the exam. Generally, if isolated splenomegaly, I will probably put my bet on mitotic and infective first. Therefore, I will mention about myeloproliferative neoplasm, which is the four that we mentioned, lymphoproliferative like lymphoma, chronic hemolytic anemia, including thalassemia, hereditary spherocytosis, and IHA. Infective, basically, you're talking about can be bacterial, viral, or parasitic. Bear in mind that IE can also present by splenomegaly and some other bacterial and virus, and also as a parasite. Leishmaniasis and schistosomiasis tends to be quite large, but generally they are not common in our setting. Inflammatory, don't forget to mention about Felty. Examiner likes this because this will kind of like make them think that we are thinking out of the box. We know this as our differential. That's why we always need to remember that always mention about this, but don't mention it to begin with if you are suspecting more like a cancer or even infection. Okay, inflammatory can be SLE or RA. Infiltrative can be hemochromatosis, amyloidosis. Vascular part, probably the commonest cause of isolated splenomegaly with stigmata or chronic liver disease will be cirrhosis with portal hypertension. So that's why sometimes I may put the vascular first and then followed by mitotic or infective. It depends on the situation. Okay. And other things that are quite rare, glycogen storage disease or sarcoidosis. Okay. So if we combine with the hepatosplenomegaly, perhaps you can always use back the same approach as well: mitotic, infective, inflammatory, infiltrative, vascular. So perhaps you also need to think that what are the features to suggest which one you are dealing with renal endowment or you're dealing with non-renal. If you're dealing with non-renal, whether there is any stigmata or chronic liver disease, or this is more like hemato, like thalassemia kind of patient, because the differential diagnosis and the priority is going to be different. If there is a stigmata or chronic liver disease, then perhaps you should mention things like what can cause the liver to be enlarged at the same time causing portal hypertension and splenomegaly. That would be alcoholic liver disease and hepatocellular carcinoma being the commonest. Okay, and let's say you're talking about cancer like malignancy, can be myeloproliferative or lymphoproliferative, or can be due to chronic hemolytic disorder, including thalassemia. And infective can be due to bacterial, viral, parasite. Inflammatory, no need to mention, is the same. The rest you can see is almost the same. And vascular is also possible because we know that patient can have a right heart failure or severe tricuspid regurg, what we call as cardiac cirrhosis, but they can cause hepatomegaly with portal hypertension as well. Other thing will be like glycogen storage, sarcoidosis, acromegaly. Okay, so for non-renal abdo-station, perhaps we should mention one, the end our examination by checking hernia orifice, perineal examination, per rectal, fundoscope, UFAM, and targeted system. And for master, probably you want to mention about history, to take history on high-risk behavior and family history, something like that. Okay. For presentation, there's no specific way. I mean, this is just a guide, but generally, this is just like a guide to present the last sentence if you want. But generally, I would prefer it's a safer way if you present from the peripherally, then go to the abdomen, then only you conclude what are the diagnosis, and you follow by this complication. Okay, so to me, it's unlike the renal endowment. For hepatobiliary as well as the hematological endowment, sometimes you are not entirely sure of the etiology. It's just like hepatomegaly or splenomegaly. So that's why you don't want to commit yourself. So it's also always safe for this reason to present from peripheral, then central. Okay, but let's say you want to present it like a short summary of the chronic liver disease. You can mention that because of the evidence of stigmata, stigmata of chronic liver disease, and in terms of complication, that is portal hypertension, can be ascites, dilated veins, as well as splenomegaly. The compensation are mainly these four: jaundice. If patient got hysteresis, that will be stage 2, hepatic and calf. Can be fluid overload as well as coagulopathy in terms of bruising. Additionally, you may also want to mention about tattoo mark and also some IVDU needling site lah. Okay, so liver transplant is something additional because we always need to present a bit more, just like renal transplant. Probably you want to mention that this patient have end-stage liver disease with a stigmata of CLD and may with or without hepatomegaly, and the currently is a post-transplant evidenced by a rooftop or reverse or even modified Makuchi incision. In terms of complication, he is not he has no evidence of portal hypertension, which include ascites, carbomedusae, or splenomegaly. He is There is no evidence of decompensation like jaundice, overload, hepatic hysteresis, or coagulopathy. In terms of complication for immunosuppression, whether or not there is presence of steroid or even like gum hypertrophy. Generally, liver transplant only maintain the two immunosuppression as opposed to our kidney transplant. Because liver transplant, we know that liver is actually a more, there's this concept called immune tolerance, in which liver is slightly less likely to be rejected as compared to other organ like kidney. Okay, they develop immune tolerance. Okay, so that's why usually they only maintain with just two immunosuppression. Additionally, you may want to mention like other scar or anything you want to find, and then if possible you want to offer the etiology. Like for classic case, like for that kind of case, you want to mention like uh the possibility of all this end-stage liver disease is due to the primary sclerosing cholangitis underlying IBD, ulcerative colitis, something like that. So liver part, for liver investigation and management, you should go by that. Generally, to diagnose and stage the severity, you can take a liver function calculation profile, calculate the child PUC score, ultrasound abdomen to look for this and that, and we'll do a diagnostic and therapeutic tapping, send for SAC, send for other things, and the non-invasive method, you may also consider calculating the FIB4 or APRI score, even do a fibroscan. Etiology-wise, you want to screen for infective screening, malignancy screening. HCC is basically alpha fetoprotein with multi-phase CT, or even some malignancy screening, age-appropriate malignancy screening. Infective screening you want to do probably will include a blood culture, serology, or autoimmune screening if you're suspecting autoimmune etiology. And liver, and basically the iron study, the copper as well as the fasting lipid profile is the so-called infiltrative disorder. And then echo if you're suspecting is a right heart failure. And if you cannot find any etiology, you may want to mention about liver biopsy. And if you're suspecting more like hematological causes, you may want to perform like peripheral blood film, BMAC, or even lymph node biopsy if that's a palpable lymph node. Complication-wise, perhaps the only four important things you need to mention is the hepatic encephalopathy. You may want to do a CT brain or to quantify the ammonia. And varicose screening basically is OGDS. And then SBP is mainly to look for any cell count and the culture. And the hepatorenal is basically want to make sure the ultrasound KUB, UFAN, and also the renal profile, something like that. Okay. Management-wise, non-pharmaco, pharmaco, and surgical. Same goes to what happened. I think everything is self-explanatory, but perhaps to explain on the pharmacological, you just go back to the complication. Make sure patient adequately being prescribed laxative, and even consider rifaximin or varicose to consider like dilapracin or octreotide, and with or without ceftriaxone. Okay, and portal gastropathy, consider beta blocker after offload, ascites, serial tapping, diuretics, antibiotic, hepatorenal like IV human albumin, telepressin, and all those things, and targeted therapy. Okay, surgical are all those like surgical intervention. The refractory one, you can mention something like TIPS, BATO, or CATO, or those very junky stuff, which is only available in certain center. And you may want to mention about liver transplant. And generally, always remember, in this kind of chronic diseases, you should mention about vaccination as well. Okay. So next is the thalassemia. Okay. So thalassemia is also, you can present it as a template if you want, because thalassemia is something also expected. The moment you look at the thalassemic phases, very obvious. But bear in mind, like, if you're not very sure this is thalassemia, perhaps because the extramedullary hematopoiesis feature can be present in other chronic hemorrhagic disease as well. Generally, they are a bit pale with tinge of jaundice, and basically they have a bit of extramedullary hematopoiesis feature. But if you're not very sure this is thalassemia, perhaps the safer way to present is, sir, I think this patient have a diagnosis of chronic hemorrhagic disease. Most likely it's thalassemia, you can present like that. Evidence by frontal bossing, maxillary overgrowth, malocclusion of the teeth, with anemia and thin or jaundice. In terms of complication, I noticed that he or she have hepatosplenomegaly, frontal bossing, and all those things. And there's also complication for hypertransfusion, which is the iron overload, in which the patient appears to be slate gait in terms of pigmentation. And I also noticed that is a finger prick mark over the fingers to suggest diabetes, sugar check, as well as there is also a insulin injection site. And I also realized that the patient have evidence of hypogonadism, in which there's loss of axillary hair. Axillary atrophy, we are not expected to check, but mainly we just screen for loss of axillary hair to look for any hypogonadism. Okay, and then whether patient got any form of like hepatomegaly, then hepatomegaly can be present for because of the extramedullary hemopoiesis, not because of secondary hemochromatosis. But let's say patient got like spinal nevi, let's say patient got like bruise mark, all those things you may want to mention that patient may have a chronic liver disease with secondary hemochromatosis. At the same time, in terms of cardiovascular, patient may have a loud P2 to suggest primary hypertension. Sometimes patient may also have ICD. And in terms of the arthropathy, yeah, I encountered thalassemia in my real exam for PACES, and the patient, I was really shocked because I didn't expect the patient is like a full blown gout. Patient has a lot of this gouty tophi over the hands and finger, and when the scenario is to examine the abdomen, I was like, okay, what is the gout relation in relation to the abdomen system? So apparently the patient is thalassemia, but the patient is so adult, doesn't have any obvious thalassemic feces. But what I realized is that the patient have tinge of jaundice, and the patient is also pale. So this two give a clue to me that this is thalassemia or chronic hemorrhagic disorder. So I actually present this patient as chronic hemorrhagic diseases, and I offer a differentiation as thalassemia. And examiner asked me what is the relationship with all those lesion that you see over the hand. I say that I think this is a gout, can be some pseudo gout as well associated with thalassemia. And true enough, when I remember that when I prepare the exam, one of the hypertransfusion complications is actually the arthropathy. So it's not common, or perhaps I should say it's uncommon. It's not uncommon to say that thalassemia can also have gout or even pseudo gout. That's why it's also something that we need to mention if present. And complication in terms of iron chelation is perhaps the dextrosamine, but generally those patients on dextrosamine, they will give some infusion pump there. So you need to recognize that the infusion pump is the dextrosamine, not like insulin pump. It's different kind of pump. And evident complication from chronic hemolysis is basically these three things. Most of the time, patient will have a PICC. Sometimes patient have chemopod, very rarely. Most of the time have PICC. If those with transfusion dependence, the moment you notice that there is a PICC, you know that this patient is transfusion dependent, full stop. Okay, so it's a very clear-cut clue. So you may want to mention that as a complication for chronic hemolysis. And please bear in mind to look for any scar. Let's say patient got splenectomy scar, patient got cholecystectomy scar, and this is also a complication for chronic hemolysis. So if you present in this way, it looks more structured in terms of thalassemia. Okay, and the investigation for thalassemia is basically everyone knows, but just to focus on the complication part, something that we need to mention routinely, in which we need to mention of the bronze diabetes, right, metabolic complication. Therefore, fasting sugar and also HbA1c, and also don't forget about the pituitary hormone screening to look for any hypogonadotrophic hypogonadism. At the same time, any other hypopituitarism, because we know iron deposition at the pituitary gland can cause suppression, hypopituitarism, secondary causes. It can also cause hemochromatosis like ferritin. Therefore, it's important to mention about the magic word about thalassemia is a T2 star of the MRI to look for the heart and also the liver. Hepatitis screening because of regular transfusion. And they are prone to osteoporosis, therefore the bone mineral densities or the DEXA scan is also warranted. Ultrasound abdomen is also warranted to look for any pigmented gallstone. Okay, and management will be non-pharmaco, pharmaco, and surgical. Again, it's the same thing: blood transfusion, PRN, dietitian, vaccination, education, counseling. Pharmaco is all those usual thing. And important for thalassemia is to mention about the iron chelation, bone protection, and in post-splenectomy patient, you want to mention about prophylactic PEN-V prophylaxis, and other thing like homeopathic stem cell. Those are the discussion part that everyone should know. Okay, so that will be thalassemia. Lymphoproliferative myelofibrosis can come out, but it's slightly rare because most of the time they are very immunocompromised, post-chemo, very frail. But those like myelofibrosis on JAK2 inhibitor or probably not on treatment one, they look very stable, they can come out in exam. So if you want to present, you also need to know that how do you do a quick summary. So we want to mention about diagnosis in terms of anemia, hepatosplenomegaly, with or without limb adenopathy. And you want to mention that there is no other stigmata to suggest chronic liver disease or kidney disease. In terms of complication, let's say this is a malignant hematological disorder, you may want to mention that there's no perinatal drift if you think of doing that. And there's, if you use an antibiotic, you may want to suspect neutropenic sepsis or even chemotherapy complication like ulcer. Those are very rare. Generally, it won't come out. But let's say it come out, you can actually mention that. And then additionally, you want to mention this extra thing like chemopod, and then you want to offer the etiology. Okay. So investigation generally for hematological disorder, malignant, you want to do a PBF to look for leukoerythroplastic picture, especially the blast, to differentiate between leukemia reaction or even leukemia. You may want to do a lab score, which is not available in most center. You can also do a BMAT. When they ask about BMAT, you can do it like an exam weight YY style. You want to say that I will do a bone marrow aspirate and trifine. For cytogenetic, I will send for chromosomal karyotyping like Philadelphia chromosome, like BCR, ABL, and for immunophenotyping, I will look for cell type differentiation, all those CD. And for molecular study is to prognosticate like JAK2, V617F, and all those things. Lymph node biopsy, PET-CT, and then complication, I want to mention about all those other things. But basically, I won't go in detail. But let's say there is a so-called myeloproliferative disease. Specific thing you may want to mention under management would be the tyrosine kinase inhibitor, hematopoietic stem cell transplant, PV, basically just venesection, and then CVS risk modification, and aspirin. If patient have high risk, as defined at age more than 50 years old, or evidence of arterial or venous thrombosis, then you should start the patient on what we call as, what is it? What's the term already? Cannot remember. But hydroxyurea, busulfan, interferon, all are considered as one of them. Okay, and don't forget about the newer therapy like ruxolitinib. And ET is mainly just the term is called cytoreductive therapy. Yeah, not is mentioned there. And myelofibrosis generally is the ruxolitinib to reduce the spleen size, the disease burden. Okay, at the same time, there's the consideration of hematopoietic stem cell transplant. Those are the like general thing. Like we don't have to know the detail. Okay, so what are the other possibilities that can come in ecto? Is the possibility of, like I mentioned, the ascites alone, isolated ascites. Then you are expected to discuss on the so-called the consultative or exudative. In the olden days, we call it, but nowadays, you just label them as SAC less than 11 or more than 11. And the second possibility is the scar. It can be rooftop modified microchip incision. Bear in mind that liver transplant indication is also important. You want to mention that what can cause the liver transplant can be due to acquired or congenital cause. Congenital causes, those patients tend to be very young. They have biliary atresia or even Alagille syndrome. For example, they underwent Kasai procedure subsequently followed by liver transplant. Or certain patients, they have only Kasai procedure without liver transplant because they are very healthy. They don't have much cholangitis episode. And acquired causes, you want to mention about the toxin, the drugs like paracetamol. Okay, also include the viral hepatitis and perhaps in Malaysia, the common one would be the HCC fulfilling the million criteria. And then if it's not because of liver transplant, you need to think of biliary procedure or even hepatectomy for some other reason. Suprapubic mass I mentioned just now. And ileal mass is something that can come out, but I don't think it's fair to come out. But always think of the possibility so that we won't panic in exam. If ileal mass is come out, then you need to think of, I'm talking about right ileal fossa mass basically. So you think of like GI causes, can be due to ileocecal TB, appendicular mass, or even like cecal mass. For GU, can be due to undescended disease, tubal ovarian abscess, ovarian pathology, or even transplanted kidney with the Rutherford Mauritian scar. Hemato causes can be due to lymphoma or even that GI lymphoma. Okay. So next we go to cardio. If anyone got any question, I will perhaps a bit fast but anyone have any question, just stop me. Okay, so cardio, I will usually, before I approach a cardio patient, I will usually remember this mnemonic called ASPA. Okay, ASPA is basically what I generally look at the patient before I do anything and subsequently proceed next. So the first thing I look at the patient when I enter the cardiovascular station, standing at the bed, at the end of the bed, is to look at the patient, whether the patient is young or patient is a bit like middle-aged to elderly. Because a young patient will tell me a lot of things that I'm expecting, like congenital heart. I'm expecting, like, for example, syndromic patient. Okay, for middle age to elderly and expecting more like valvular heart, it can be a native valve, it can be a it can be a mechanical prosthetic valve. Okay, or it can be a complex heart as well. Okay, and the next thing is the S is a syndrome. So I need to generally screen through all the possible syndrome that can happen in cardio station. For example, Hoff-Oram syndrome, you expect there is a tripharyngeal thumb, there is hypoplastic the hypoplastic fingers. Okay, then you will suspect more. Even before you exculpate the patient, you are suspecting like ASD with MS kind of thing. Okay, and Williams syndrome, if you think patient is dysmorphic, you need to really screen through whether patient have a possibility of a certain particular valve issue. Okay, and Marfan syndrome basically can be mitral regurg, can be mitral valve prolapse, can be AR. Okay, and ankylosing spondylitis basically is also important. Remember when you ask patient to lie at 45 degrees, make sure their neck is touching the pillow completely. If the neck is not touching the pillow, then you know diagnosis is ankylosing spondylitis. Okay, it can come out as well. Sometimes it's a bit tricky, right? So AS, you are suspecting again same as Marfan as well. Noonan is very special. You are thinking more like pulmonary stenosis already, right? And Turner can be a lot of things. Most of the time, coarctation will not come out. But what are the things that can come out in Turner is actually, it can be a septal defect, or it can also be the aortic regurg as well. Down syndrome can be ASD, VSD, or ABSD. Pseudoxanthoma elasticum, I never see anyone before, but in overseas it can be quite common. In Malaysia, it's very rare. So generally, I will use this how man turn down P to kind of like screen through. Generally, if I don't think patient is dysmorphic, then I think it's safe to proceed. But sometimes we will not realize that patient is very tall. We will not realize that patient got arachnodactyly. We will not realize that patient got high arch palate. We may miss things here and there. Okay, so please bear in mind that you want to screen for syndrome. And the next thing, when you open up the patient chest, the precaution is to look for any scar. Be it the left infraclavicular scar, can be due to any cardiac implantable devices. Midline sternotomy scar can suggest a few things. If it's a young patient, you will suggest a congenital heart repair. If it's a middle age to elderly, you're suggesting that this can be CABG, or this can be valve replacement, or can be both. Okay, lateral thoracotomy scar, you are talking about like BT shunt for congenital heart, or even like Marfan, you're talking about bulectomy. Okay, and bear in mind that nowadays more and more minimally invasive surgery is done, especially even CABG as well as valve replacement. So you need to know that this MIS scar is actually very common. It can come out as usually the scar is situated at the right chest wall, and it's very small, measuring almost about 6 to 7 cm, transverse incision, or even can be a bit longitudinal kind of incision. So usually, if you want to know the scar in detail, you can see my another video on the scar and devices. So there's a lot of photo from there. So, but basically, bear in mind that even the scar is at the right lung, at the right chest wall, it can use to actually replace the mitral valve or even the aortic valve. No difference. You know why? Because in the surgery, in the cardiothoracic surgery, what they do is actually they use single lung ventilation. They ventilate they ventilate the left lung, and they collapse the whole right lung. So after the right lung is collapsed, the whole heart will be shifted, and they generally, to them, the mitral and the aortic is just up and down. It's just very near. Okay, so bear in mind that even the MIS scar is there, it can mean the mitral valve replacement. Okay, not just like possibility of just aortic valve replacement. And sometimes you also need to think about, can this be like a dual valve replacement? Can this be also include the triple valve replacement, including the tricuspid? Okay, so that can make the situation tricky. The next thing is, when you start to examine the patient, you feel for the pulse. Pulse can tell you a lot of things. If the pulse volume is low, then you're thinking more to stenotic kind of pathology. If the pulse volume is good, then you're thinking more to regurgitation. If the pulse is regular, then perhaps you're thinking more to other pathology, or can be normal. But if a pulse is not, is irregular like AF, then you're thinking more to mitral pathology. Commonest being MS, but it can also occur in MR as long as the LA is dilated, right? Okay, left atrial appendage. So when you proceed further, when you feel for apex beat is also equally important. You want to know that for two reasons. First reason is you want to know whether apex beat is deviated or not, is displaced or not. Actually, for MRCP level, you just need to know whether you just need to comment whether the FSP is displaced or not displaced. But for master, I think you need to tell at which intercostal, at the mid axillary line, you have to present very detailed, right? That's the master level, because they have a longer time. The examination is like 10 minutes, something like that. But basically, for apex beat, the most important thing is to identify whether it's displaced or not displaced. Because if it's not displaced, then you're dealing with more to like stenosis pathology. If it's displaced, it can be due to regurg or even in the mixed pathology. And please bear in mind that don't ever miss a dextrocardia in a congenital heart. It can happen because if we don't palpate the apex beat properly, we will assume everything is not displaced, even though we cannot really feel the apex beat. If you cannot feel the apex beat, you should lie the patient to the left lateral position to feel. If you really cannot also, then it's time for you to feel for the right chest wall, okay? Because it can come out in exam with just dextrocardia alone. There's no murmur, or even dextrocardia with VSD also happened before, okay? So it can come out in exam, can be tricky. So cardio, you're dealing with native valve, mechanical prosthetic valve, or you're dealing with congenital heart. Mainly, you're dealing with these three possible scenarios. And under these three titles, if it's native heart, you're dealing with isolated or mixed. It can be like mitral pathology, be it stenosis, regurg, aortic pathology, or even like pulmonary etiology. Mixed usually is like MSMR, ASAR. Then you need to decide which one is predominant. And mechanical prosthetic can be single or can be combined. Okay, so we need to very clear that you really need to know how to listen for mitral clicks and also the aortic clicks, S1 or S2. You need to tell yourself this is S1 or S2. And for DVR, you need to differentiate between whether this is a true DVR or this is actually a cage and ball valve replacement. Bear in mind that cage ball, what we call as a Star Edwards valve, is only applicable for mitral valve. Okay, they never use it for aortic valve basically. So if cage ball came out in an exam, the way to differentiate between door valve replacement is the sound of these clicks. Okay, cage ball is not much of crispy sound. They actually can be heard like a ping pong kind of oscillation kind of sound, pop 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 like that. But in a true mechanical click kind of valve replacement, it's very crispy. It's like very S1, S2 also you will see the click. Okay, so that's a good way to differentiate between Star Edward versus a dual valve replacement. You should be able to differentiate if you encounter any patient with such a finding before. Okay, and if you're dealing with congenital heart, you're dealing with either this is a acyanotic heart or this is a cyanotic heart or this is a what we call as combined, and the last one is actually the dextrocardia. If it's an acyanotic, you're talking about ASD, VSD, or PDA. If it's a cyanotic, then this can be corrected TOF, can be isomeningeal, or can be complex congenital heart. So the commonest that come out in exam usually is the either corrected TOF versus isomeningeal. So we need to differentiate between them. So this is just a nice table to tell you when you auscultate at a different area, what are the things that you should expect. Just to add on this table, when you auscultate the upper left sternal edge, if you can hear ejection systolic murmur at this pulmonary area, which essentially with expiration or even in inspiration, don't forget to also consider the possibility of Hokum. Okay, Hokum can be listened up or down at the left sternal edge. Hokum can come out in exam in which they may have a pacemaker at the supraclavicular region, and you only listen the ejection systolic murmur. It can come out in exam as a Hokum. Okay, but you always need to offer the differential diagnosis first as like aortic stenosis or sclerosis, depending on whether there's any carotid radiation. And the other thing is very rare. Pulmonary stenosis, I would not even mention unless patient is very young or some syndrome. Okay. And there's also a famous, like very severe AS causing Gallavardine phenomenon. That's why under this PSM at the apex, you should always have a differential of, can this be MR or Gallavardine of AS? Okay. But generally, how you differentiate between these two is you should not expect radiation to axilla in Gallavardine phenomenon. Okay. Because when you hear the murmur at the axilla for severe AS, you should only hear the ejection systolic murmur, not the pansystolic. This kind of seagull Gallavardine phenomenon only occur at the apical region, which is a high pitch. The AS is actually the low pitch lah. So because of the high pitch and low pitch, you will actually manifest as seagull kind of sound, like that, something like that. Okay, and then late systolic murmur can be due to mitral valve prolapse, and mid diastolic murmur. Remember that other than the mitral stenosis, which is hardly we can appreciate, but most of the time the loud S1 is the one that gives us a clue. If you realize that the S1 is actually very loud, then you really need to suspect whether this is a mitral stenosis. Okay, and bear in mind that there's other possibility of mid diastolic murmur, which is Austin Flynn murmur or even Carey's cone murmur. Okay, so mitral stenosis sorry, mitral or aortic in terms of regurg or stenosis, in terms of clinical severity and surgical indication, I think I leave everyone. This is generally what I used to remember when before I go for exam lah. Because we need to know the surgical indication to replace the valve. Like for example, MR, I will remember this is like 50 is in between. So below is 45, above it is 60. So I know that the LVESD is more than 45, with LVEF less than 60, and then the estimated pulmonary arterial pressure is more than 50, something like that. And then the aortic regurg, I will remember everything as 50, 50, or 55. In the latest ESC guideline, this LVESD cutoff is already become 50 lah. So you want to mention everything 50 is not wrong. This is actually based on the previous update, not the latest one. The latest ESC update for indication, surgical indication for aortic regurg is actually 50, 50, and 50 already. So it's easy, even easier to remember. And remember, the way I remember this is for regurgitation and stenosis, when it comes to the surgical indication for replacement, usually regurgitation is more like technical stuff. It's like, quantity. We're talking about numbers, right? But when it comes to stenosis, it's more like quality, right? You're talking about whether patient got any hemoptysis, pulmonary hypertension, recurrent thromboembolism, got any hypotension or exercise stress test, got any VT or not, or any LV dysfunction or not. And then only because the aortic stenosis, because if it's too severe, that comes the technical part. If it's the AVA less than 0.6 or MPG more than 40, that is already indication. So this is something extra. So mixed valve, how to differentiate between both, I won't go through. If you all want to know in detail, you can just go back to my previous recording. And I would perhaps focus on this very common scenario. Can come out, both patients will be club, both patients will be young, and both patients will be sinus. It can be peripheral sinus, it can be, central sinus. It may not even have cyanosis, but the tongue appears like, blue or even purple. And then usually they will have significant tubbing. So both of them are the same. How to differentiate? So the way I differentiate it is very simple. I ask 3 questions. First question is whether there's any scar. Because TOF must have a scar, a BT shunt scar. It can have a midline sternotomy scar with lateral thoracotomy, or it can just have lateral thoracotomy scar with a mini laparotomy, sternotomy scar is also possible. But the cutoff is patient must have scar for repaired TOF. Okay. For isomeningeal syndrome, usually patient will not have any scar. Usually will not have, because if have any scar, let's say this is a VSD that become isomeningeal, if they have an open midline sternotomy scar to patch the VSD and fail, then if become isomeningeal, it means this patch fail simply means. So usually it means that isomeningeal will like a natural progression of ASD, VSD large enough, or even PDA not close, therefore become develop right to left shunt and isomeningeal. That means usually they don't have scar. But if they have scar, meaning it's a failed repair. The second thing is the murmur per se. So in the TOF, murmur can have 2 possibilities. It can be ejection systolic or it can be early diastolic murmur. But generally, you know that TOF is a 4 things together. Okay, there's a VSD, there is overriding aorta, there's RVH, and there's also a so-called functional pulmonary stenosis. This functional pulmonary stenosis is due to supravalvular pulmonary stenosis. It's not at the valve per se, but actually the narrowing above the pulmonary valve, causing the so-called functional stenosis. So if what they do in the TOF repair is they close up the VSD and they open up the functional constriction of the pump just above the pulmonary valve. So if they open up too much, they will actually cause pulmonary regurg, right? Therefore, you will hear early diastolic murmur at the pulmonary area. But if they say they repair, let's say after they repair, this narrowing comes again, then it will be too tight already. With stenosis, we call it. Then you will hear early systolic, ejection systolic murmur. Okay, and usually for isomeningeal, you will not usually hear any murmur because already got reversal or shunt. But usually most of the time, isomeningeal will already develop pulmonary hypertension. So TR is expected. Okay, you may have TR pansystolic murmur at the left lower sternal edge. When you do a maneuver, accentuate with inspiration, not expiration, then you know that this is a TR. This is not MR. This is not other thing. So this possibility, if that's the possibility, then this is more like isomeningeal. Usually TOF will not have pulmonary hypertension. They should not have pulmonary hypertension because they already repaired. They are well already. Okay. So back to the point of pulmonary hypertension. Therefore, TOF should not have a loud P2, but isomeningeal should have a loud P2 with a parasternal heave with or without TR. Okay. So another thing about cardio is want to complete examination by doing all this lah. And pulse pressure is also important. If you think this is AR, you should look for widened pulse pressure. Okay. If you're AS, you should look for a narrow pulse. And then other thing like to rule out the IE part, fundoscopy, urine dip. And something additional I want to mention is the pronator drift. If you're suspecting if you're dealing with a mechanical prostatic valve repair, you need to check for pronator drift to as a showmanship that you're checking for complication of anticoagulation. Because mechanical valve replacement, definitely the only option is the warfarin. There's no other option already other than VKA. So for warfarin, you need to check for a few things. So the way I remember for warfarin is actually the TAVI, TAVI. T is actually what is T again? Cannot remember. Suddenly brain stuck. Okay, T is actually I cannot remember what is T again. But basically A is actually anemia, V is actually valve dysfunction, I is actually T is thrombotic. Now I remember thromboembolism. That's all because of T. I check for pronator drift. A is anemia. Okay. V is actually valve dysfunction. What I don't want to hear in a valve replacement patient is if I'm replacing a mitral valve, I do not want to hear a valve failure, which is a mitral regurg valve, which is a pan-systolic murmur. For aortic replacement, I should not hear a early diastolic murmur, which is to actually suggest aortic regurg. So the valve dysfunction is basically you want to look for this pathological murmur, okay? And then the remaining I is the infecting endocarditis lah. So TAVI is what I used to remember for the pneumonic for complication of anticoagulation as well as the mechanical replacement valve. And also don't forget to offer to check for INR records lah, okay? So presentation, this is how I usually do. I would say that this is a young or middle-aged man or lady, with or without any syndromic features. I think he has a diagnosis of. Then this point, you want to go straight to the point. What is your murmur? What is the finding, accentuation, the characteristic, quantify everything, and then the severity and the symptom. Let's say the scenario mentioned that patient having SOB, and you got the diagnosis of MR with AF. Then this is definitely symptomatic MR already warranted for surgery, right? Because you know that MYH 9 3 and 4 alone with this severity of the valve is indicated for surgery. Okay. And additionally, you want to mention about the device, the scar, if you found anything. Complication is the one that you need to mention everything. Cardio is very particular. Whether there's any evidence of heart failure. So right heart failure, very simple. RHF, right heart failure. You're talking about any risk JEB, any hepatomegaly, or any foot edema. Pulmonary hypertension, PHT, is also very simple because it also signifies severity. Very simple to remember. If you got only palpable or loud P2, there's only mild pulmonary hypertension. If you got parasternal heave, it's already moderate. And if you got TR, it means it's severe pulmonary hypertension already lah. So PHT, okay, very simple as well. If it's isomenger, you are expected to mention that patient is sinus, club, whether or not patient got any pulmonary hypertension lah. And the next thing is the AF, whether functionally patient is in AF. And then for prostatic valve, you want to mention about TAVI that I mentioned just now. And you also want to mention about IE stigmata if you haven't mentioned about, you want to look complication-wise, there's no petechiae or Janeway vision. However, I want to check further to assess whether there is sphincter hemorrhage or any oscillar node. Okay. And then in terms of etiology, cardio only got 5 or 6 etiology that you should mention. It can be IE, rheumatic heart, degenerative calcification if it's too old already. Too young can be due to congenital like bicuspid valve, parachute valve, or connective tissue disease like MOPE, we call it MOPE, Marfan syndrome, osteogenesis imperfecta, pseudoxanthoma elasticum, Ehlers-Danlos syndrome. All those are like hyperelasticity syndrome. Or it can be due to autoimmune disease like SLE and RA. Okay, so these are very tempered. Cardio is a station that you should really score because it's very tempered. There's only a few possibilities that can come out. The problem with cardio is just to get the correct sign and cannot confuse ourselves. Okay. So investigation is also very straightforward. Bedside, you want to mention, do a ECG, blood test, you want to check for IE, inflammatory markers, some other thing like coagulation profile if patient is on anticoagulation, functional like echo. Echo, you want to mention what you want to do, you want to confirm the diagnosis, stage of severity, exclude the complication. And then imaging wise, you want to do an X-ray or even like cardiac or CT, depending on the etiology. And also, actually offer the possibility of coronary angio, especially prior to surgery or even any valve replacement. So supportive and specific, no need to mention in detail. Everyone knows how to present it. So next is the neurology. Okay, no, now it's like 10 o'clock. Okay, so neuro is quite tricky. In fact, most of the perhaps it's a harder station because we are all often lack of time. And time is therefore very important for us to decide what are the things that you should do the most to get the finding that the examiner calibrated in exam. So we really need to do more. So it's no longer just cranial nerve, upper limb or lower limb or even like gait examination anymore. It is a combination of all, and you need to budget your time to find the sign that the examiner want. Okay, not the what, not the sign that is like all the soft sign. In the short case, we always when the examiner calibrate, they always got soft sign and also hard sign. Hard sign are the one that they say they will think that if you cannot get the hard sign, you only get a soft sign, then you will fail. But hard sign is something that if you get the hard sign, you don't get the soft sign, then you will still pass or you won't get the full mark sometimes. So it's important to know what are the possibility that can come out in exam. Therefore, you will anticipate that what are the hard sign you need to mention. Okay. So therefore, because the time is very limited, you need to really read the stem carefully. So if the stem mentioned to you that to examine the cranial nerve, basically it means that you need to look at the face properly, look at the eye, face, or bulbar. There's only three possibility. It can be anomalies at the eye, like ptosis. It can be abnormality at the face, like six or usually six under eye as well. Face is usually the seven nerve, upper or lower motor neuron, unilateral or bilateral, and whether it's isolated or combined. And bulbar is the one that is a bit tricky. If the station asks you to assess the speech, hardly come out in the MRCP, but master I think is possible. So we need to really, if that's a stem, then you have to check the cranial nerve. For upper limb and lower limb, it's no longer sufficient if you just check tone, power, reflex, sensation, and coordination. You need to you need to finish this five component fast and tell yourself that whether this is symmetrical or asymmetrical, whether you're dealing with proximal or distal, and you should proceed to look further whether this is upper motor neuron or this is a lower motor neuron. I will talk about it later. Because if it's a spastic or what we call as upper motor neuron, you want to check a bit more. You want to look the neck, the back for any scar, and you want to screen the eye for RPD, nystagmus, and also INO. The reason I'm saying that for spastic paraparesis, you're thinking more to demyelination in a young patient, or you're thinking more to, a lot of things that can happen in the brain can also happen in the spine. You're dealing more about demyelination as a top differential, or even like sometimes can be due to malignancy. Okay, so you may want to look for all this. For flaccid paraparesis, usually what I do is I will focus hard to check for myopathic sign, especially when there is a wasting, be it proximal, let's say it's a proximal wasting, proximal muscle wasting, symmetrical proximal. So I will focus hard to screen for myopathy. First, I will look from the top. I can look from the top to bottom, or I can do from the bottom to the top. I prefer to do bottom to the top. I will look for the cuff or any pseudohypertrophy of the cuff. I will ask patient to squeeze my finger quickly to look for any evidence of delayed relaxation in dystrophia myotonica. I will ask patient to push her hand against my hand to look for any scapular minging, or even ask patient to just lift up the shoulder both sides and observe the back for any scapular minging. I will also quickly look at the face to look for any seven nerve palsy, assess the speech. Can ask patient to do, can you repeat after me, like British Constitution, things like that, to assess for any bulbar palsy, any slurring of speech. I will also look for any rash to suggest dermatomyositis. And if patient have any like Cushingoid features, acromegaly feature, then I will know what's the cause lah. But basically, we need to screen through this myopathic screening. If let's say we are suspecting that, because that's the only way we detect it. Sometimes you cannot get the etiology. If you just start at if our examination is not smooth and patient is not cooperative, and we just start at tone, power, reflex, sensation, coordination, sometimes we may not able to get the full marks, because we need to really know what is the etiology, okay, if possible. And regarding the lower limb and the gait, it's always important that if the stem asks us to examine the gait, like the stem asking that patient have some difficulty in walking, patient has some instability in walking, patient have frequent fall. So please don't examine the lower limb. Straight away ask patient to walk. Okay, because the time is short. Meaning to say, if the examiners really decided to put this as the stem, it meaning they want you to appreciate something over the gate in which they calibrated something as a hard sign. Okay, don't go and examine the lower limb only then you do a gate. We need to be very flexible, cannot be too rigid, because if the stem is examining the gate, it will lead to extra pyramidal approach, which is the cerebellar or Parkinson station. If you are sure and confident that this is not cerebellum, this is not Parkinson, then you just proceed with lower limb. Because either way, let's say you miss the high arch, high steppage gait, or let's say you miss the other form of gait, is okay, because lower limb you appreciate some other sign, but you cannot miss the cerebellum and also the Parkinson because they are own domain. You have to check different things, no longer focusing on lower limb examination already. So if the stand asks you to examine lower limb, then you have to examine the lower limb first, okay? Because the gait will not be the main thing that the examiner calibrate. This is from examiner point of view. Therefore, after we knowing this, we need to know, you have to read the stand carefully, okay? And at the end of the day, you need to tell this is upper motor neuron or lower motor neuron, and whether this is a mix, okay? So back to the basis. So what are the possibility? Cranial nerve, you're focusing on eye, face, and bulbar, right? It can be second nerve or third nerve. If it's third nerve, it can be isolated or combined. Combined meaning to say is 3, 4, 6, okay? And face, it can be 7, okay? It can be unilateral, bilateral, combined, or isolated as well. Combined, I'm talking about other things, like for example, you're talking about CP angle tumor, all those things. Bulbar, you're talking about 9, 10, 11. Okay, so we need to really know what are the things that the examiner want us to detect. Okay, next thing is the upper limb and lower limb. You need to tell this is a spastic or flaccid. You need to tell yourself this is asymmetrical or symmetrical, and that is that. And then next thing is proximal or distal. This is for the upper, examine upper limb and lower limb. There's also a possibility of coming up with a stem of peripheral nerve, okay, which is the foot drop, commonest being for the lower limb, and the upper limb is just either it's the wrist drop, either it's the for example, like carpal tunnel syndrome or even ulnar or cubital tunnel syndrome. Those kind of patients can come out as well. Okay, we need to know how to examine them. And the third possibility is the gait. Okay, we know that the extra pyramidal is just Parkinson and cerebellum. Cerebellum, you need to tell yourself whether it's a unilateral or bilateral, whether there's pyramidal or non-pyramidal involvement. Pyramidal meaning to say there's upper motor neuron sign. Non-pyramidal meaning is a lower motor neuron sign lah. Basically, Parkinsonism, you need to know whether this is just a Parkinson, idiopathic Parkinson disease, asymmetrical onset, and then got all the signs of classical Parkinsonism, PD, or this is Parkinson plus. Okay, this is something we need to check as well. Pyramidal, you are checking at whether this is the upper motor neuron. It can be hemiplegic gait or spastic gait. Lower limb, lower motor neuron, basically you're talking about high steppage gait or wobbling gait. You can see that if you miss the Parkinson or cerebellar sign when you examine the gait, and you will basically miss the whole station. You will lost the station definitely. But let's say you manage to detect that you're sure that there's no broad-based ataxic gait, there's no reduced arm swing, no shuffling gait to suggest Parkinsonism. You're very sure already. You can just proceed to examine lower limb, and you will not miss the hemiplegic or spastic, or even like the foot drop, like the high steppage gait, or even wobbling gait, because of the power and everything will tell you the rest. So that's why it's important for you to prioritize. Okay, so before we begin, always remember it's important for us to mind our step. Okay, minds our step. The reason I put in minds our step is because we need to look hard before we do anything. The neuro station, the main point for us is actually the power of observation. We need to observe first before we do something. So M is the muscle wasting. You want to look for any form of muscle wasting, whether this is proximal, whether this is distal, or this is both proximal and distal. You need to know whether this is which one is this, okay, and whether this is symmetrical or asymmetrical lah. Next thing is the involuntary movement. So you want to see for any involuntary movement like fasciculation or not, and whether there's any resting tremor. Okay, especially when the patient stressed and you talk to him or her, the hand will start to shake. Then you know that okay, this is Parkinson already. Okay, and this involuntary movement, or whether sometimes patient Parkinson develop drug-induced chorea, so they will have here and there those choretic movement. Then you know that okay, most likely this is also like Parkinson or even like extrapyramidal system. N is the neurocutaneous stigmata if have. D is a deformity. It can be deformity at the joint, deformity at the limb, or deformity at the spine. So you need to see one by one, okay? And the scar can be scar at the muscle, nerve, or tendon. So for example, you know the scar is here at the bicep, then you know that this is proximal myopathy. Most of the time, it's the proximal muscle that's involved. Okay, it gives you the clue. And this patient is actually a patient with ankylosing spondylitis, did some cervical spinal fusion surgery, and therefore you see there's a scar over the neck. Okay, And this one is also scoliotic repair surgery, very long transverse surgery. They may have some complication like myelopathy or even radiculopathy. So if you're able to detect this, then you know that, oh, okay, you will definitely they will calibrate this as the heart sign if present. And another sign, this one is the very near our quadricep muscle, right? So this is a quadricep muscle biopsy. So if you know that this biopsy scar is there, then definitely you know that, okay, so definitely it's proximal already. You cannot be suspecting distal myopathy by your biopsy at the proximal, right? It doesn't make sense. So that's why it's important for you to really appreciate the scar. Okay. And the next thing is actually the tendon. Bear in mind that this is like a to know how to differentiate between Achilles tendon release scar versus what we call as the sural nerve biopsy and versus the tendon repair scar, you can refer to the previous recording. That one, under the scar and device station, I think I have go through more detail lah. Okay, so other than that, when after you finish examine, if you got time, most of the time you don't have time. Neuro is like very rush. So you want to mention about, you want to check for postural BP, vital sign if it's relevant. You want to complete the examination for the other domain that you haven't managed to check. For example, you examine lower limb or upper limb, you didn't manage to check, so you may want to mention, I want to check the other things like cranial nerve and gait as well. And if it's dealing with myelopathy, then you may want to offer a colorectal examination to look for anal tone and saddle anesthesia, fundoscopy to look for any papilledema, retinopathy, or assess a higher mental function, like for example with MOCA or MMSE in Parkinson, carotid break if you're suspecting this is a stroke hemiparesis, cardiovascular examination, again, AF, HOCM, blah, blah, blah. All those things are the complication that you want to assess depending on the finding that you appreciate. Okay, for Parkinson, you can assess the writing, you can assess the Archimedean spiral, asking patient to draw a circle according to the tracing, or even the MMSE lah. Oh? But generally, this is all just mentioned only. Okay, so presentation, usually in general, we should tell ourselves when we present is whether this is upper or lower motor neuron lesion, evidenced by your TPR-CS, and you should give the anatomical diagnosis as well as etiological diagnosis. Anatomical diagnosis at which level? Okay, at which level? And etiological diagnosis, it can be like, vascular, inflammatory, infective, metabolic, and all those things. And additionally, you want to mention what are the things that you found, like deformity or even scar, and complication, what are the functional status of the patient. If you see a walking aid there, you know that the patient is immobilized, require walking aid. If you see a right still or pec tilt, you know that patient have some swallowing difficulty, dysphagia. If you see patient is on long-term CBD, or even like subarachnoid catheter, you know that patient may have some urinary incontinence. So these are the things that functionally I think is important for us to mention if you realize that. Okay, so I won't have time to go through everything, unfortunately. So to know in detail, basically just go back to my previous recording. But basically, third nurse is important. If patient have unilateral ptosis or bilateral ptosis is more to systemic cause. Unilateral ptosis is more to basically you want to rule out a few things only lah. First, you want to make sure you don't miss ocular MG or even a generalized MG. And next thing is you want to make sure that you are not dealing with Miller-Fisher syndrome, or you're not dealing with other thing like, for example, what other thing is actually the basically is if it's a isolated, if it's a combined like this, like 4 and 6 is also involved, whether V1 or V3 is involved, that will be different. It's a bit complicated because that will help you to localize the lesion at the cavernous sinus, superior orbital fissure, or even orbital apex. Okay, so I will not go through in detail. Okay, if you want to know in detail, you have to go back to the previous recording. And if you have excluded MG, the next is the Miller-Fisher, excluded there's no areflexia. The next thing is actually the ocular pharyngeal MG and also the CPEO. CPEO basically just have to mention that you want to check for fundoscopy for any basically you want to look for the rods and also the pigmentation to suggest the retinitis pigmentosa, as well as any feel for the pulse to look for bradycardia or even that pacemaker insertion. We know that prolonged PR, first degree heart block, is commonly associated with CPEO, as well as the RP as well. Okay, next thing is the bilateral ptosis, usually is systemic causes. Okay, next thing is don't forget the Horner syndrome. So sometimes Horner, you need to know that if the patient have ptosis, you need to recognize that which eye got ptosis. Okay, so you see that this eye actually got ptosis because to define ptosis is actually the superior limbus of the iris up to the upper border of the upper border of the pupil. So if it's like more than one third of it is actually being covered, like in this patient, this is definitely ptosis lah. Oh, okay. So if this is a ptosis, you need to know the pupil size, whether it's equal and whether it's a constricted or dilated. In this patient, definitely it's a Horner. You know that there's a constricted pupil and it's a actually there's a uh, left partial eye ptosis. So in this condition, you need to know which order you're dealing with. You need to check one by one. So because it's a second nerve, so you proceed to check at third nerve, 4 and 6, and look for any H test during the time you want to check for any nystagmus to suggest lateral medullary syndrome. It can be due to like V1 to V3 distribution, or even the cape-like sensory loss, we will suggest a syringomyelia. And other thing, you want to check upper limb to look for any myelopathic lah, to suggest demyelination. This will be quantified as the first order. Second order is usually the one, either the lymph node, cervical, rib, or even the Pancoast tumor lah, the commonest. So it's either from the sympathetic trunk, from preganglionic, which is the at the level of sympathetic trunk T2, T1, T2 up to the superior cervical ganglion. So you should check for the neck, the scar, the lung, the percuss, and then check for any bruit lah. And then third order, basically from the superior cervical ganglion up to the orbit. Basically, you are just checking for any carotid bruit, any chemosis of the eye. That will complete the Horner examination lah. But to know in detail, I will please refer back to the previous recording as well, because I don't have time to go through everything. And the seven nerves is also quite famous. Sometimes patient is the Bell palsy and can come out in exam because it tested her to check for everything. Everything is negative, therefore the diagnosis is Bell palsy. So first is to recognize that it's a facial palsy. So like this patient, the patient has actually loss of nasolabial fold which side. You need to know that which side is abnormal. Therefore, the loss of nasolabial fold is actually at the left side, right? Cannot see. And you can see that the wrinkling of the forehead, this has no wrinkling. This one basically just to check the mouth, but you ask patient to wrinkle, there's also no wrinkling. So you know that both it does not spare the frontalis muscle. Upper and the lower are affected. This is a lower motor neuron facial nerve palsy, and this is a unilateral, not bilateral. Okay, so the first question you want to ask is there a facial palsy? Second is a symmetrical. Third is upper or lower, based on the frontalis, whether it's preserved or not. And the fourth question is actually to actually elicit whether it's isolated or combined. Okay, so if it's a unilateral like this patient, you need to possible lesion is actually from the highest to the lowest is actually the pontine millet gabler, which is you are expecting a 7 nerve palsy with a contralateral hemiparesis. It can also be CP angle tumor, okay, in which you expect some nystagmus, some hearing loss, okay. And next thing is the Ramsay-Hunt geniculate ganglion. Usually you expect, basically you will just expect isolated 7 nerve with a different level of localization we will mention. And next is at the level of parotid gland. Therefore, you want to check for any parotid swelling or parotid tumor, or even any like amyloidosis, those kind of patient with parotid enlargement. And if you cannot find any cause, the possible etiology is just Bell's palsy. Okay, so how should you do? I don't also have time to explain in detail. You can refer to the previous one. But basically, you just want to confirm first, and you check for the up and the down. So if the problem is at the 7 nerve, you want to check at the 6, but you cannot just check at the 6. You have to check for 3, 4, and 6. So after you check for 3, 4, and 6, after that you will check for 8. After you check for 8, you want to also elicit whether there's any bulbar involvement. Therefore, you also have to complete until 9 and 12. Okay. So if let's say you check as 5 and 8, let's say that is actually involved. So 5, 6, 7, and 8 is involved. You should proceed with cerebellar sign. And because 5, 6, 7, and 8, we know that it's actually at the level of pon. Okay, so the next thing is whether this is an isolated pontine lesion or this is a lesion combined with a cerebellar lesion. That's why you want to look out whether there's any cerebellar sign. So you proceed to check for DDK, dysmetria, and don't forget to check for scar, the post-auricular region, to look for CP angle tumor. And sometimes CP angle tumor is associated with a type 2 neurofibromatosis. You want to check for any neurofibroma over the hand as well, or even a whole body in general. And let's say there is no cerebellar sign, you still proceed to check for pointer drift and to look for contralateral hemiparesis, which will suggest the Millet-Gabbro syndrome pontine lesion. That means the isolated pontine, not combined with cerebellum. But let's say after you check all the cranial nerve, you realize that there is also just isolated seven nerve involvement, then you should proceed to check for any ear vesicle, shine the torchlight at the ear as well as the throat. The heart palate can also have vesicle to suggest Ramsay-Hunt syndrome. Palpate for the parotid gland to look for any mass. And if you cannot find anything, you will offer etiology as Bell's palsy. But Bell's palsy does not stop there. You should also end your examination to request to check for lacrimation loss of the patient, whether patient cannot cry, and whether there's any loss of taste at the anterior two-thirds of the tongue, and whether there's any hyperacusis to localize the lesion. The lesion. Let's say it's hyperacusis is actually at the nerve to uh, tympani. What is it called? Tensor tympani. Yeah, nerve to tensor tympani. Okay. So whether there's loss of two-thirds of the tongue, that will actually localize at the level of near the. I cannot remember the localization. Anyway, you all read about it. And then the other thing about it is actually to rule out demyelination. If let's say there is if you got time. So you can also rule out demyelination by checking the second nerve. But if you have time. Generally for bilateral, you are focusing more on different level of lesion. If it's MMJ, you are talking about MG. Nerve is just GBS. Muscle is just all the myopathic. Dystrophy myopathy or even like facial scapular muscular dystrophy. Okay, I won't go in detail as well. But basically, this is what we should write and what you should fill out. You should write this table before you go to exam because it's very important for you to know the pattern recognition. So you should classify yourself like upper motor neuron. What are the level of lesion? It can be cortex, internal capsule, brainstem, cerebellum, and spinal cord. And you should write the y-axis to be pattern of weakness, reflex sensation, and additional sign. So this will help you to differentiate. Like for example, pattern of weakness in the cortex, it should be contralateral. And if let's say the MCA territory is involved in stroke more, the upper limb will be more involved compared to lower limb. If it's ACA, then the lower limb will be weaker than the upper limb. And let's say the internal capsule will be just contralateral side. It can be pure sensory motor or pure motor, or it can be ataxic hemiparesis. And brainstem basically is just cross paralysis, but having said that, it can be normal in Van-Den-Berg syndrome. Because Van-Den-Berg syndrome or so-called lateral medullary syndrome is a pure sensory involvement. Okay, the 4S is just sensory. There's no motor component. Okay, and then cerebellum is actually can be unilateral or bilateral, and then can be what we call as pyramidal and non-pyramidal. Spinal cord issue is paraparesis, and then reflex generally all is hyperreflexic. Cerebellum depending on whether it's pyramidal or non-pyramidal, and spinal cord we know is at the level is hypo, below is hyper. Sensation contralateral, but having said that, normal in pure motor is for internal capsule, but for cortex definitely is involved. And brainstem is alternating tomo analgesia. And then sensory for cerebellum will have ataxia. And then spinal cord, depending on whether it's a complete will have sensory level, incomplete, then you have dissociated, you have dorsal column, you have hemi like in this what is the hemi again? I cannot remember already. It's the lateral spinal thalamic loss with contralateral dorsal column. It's the cannot remember suddenly. But anyway, yeah, correct. Yes. So there's also it can come on exam actually, Brown-Sequard syndrome, but it's not common because it's difficult to find this kind of patient. And additionally, what are other things that you need to rule out? This is just how do you localize. You should write this table down before you go for exam. And for lower motor neuron, also the same thing. Go by pattern of weakness, reflex, and sensation. We got different level: anterior horn cell, nerve root, peripheral nerve, neuromuscular, and muscle. You all write it down and you just cross-check with this. I won't have time to go through everything. And basically, just want to go through this. If you got spastic or flaccid paraparesis, after you check the tone power reflex sensation, you should really look for etiology. Spastic paraparesis, there's only a few. Mainly you want to rule out demyelination and MMD. So basically you can start with top to bottom or bottom to top. Like I mentioned, you want to start with top, fine. You check for the eye first for any RPT, INO, and nystagmus. Basically, you just shine a torchlight to check for RPT, and then you just do a simple H test. You will see whether there's any INO and also nystagmus. And then following after, you can just ask patient to protrude the tongue, look for any fasciculation, or even just open the mouth and then even assess the speech. And then after that, you will just quickly screen the upper limb, check for any inverted supinator jerk to suggest any sensory level higher up, any Hoffman sign. And the next thing is the cerebellar sign. You want to screen for any cerebellar sign quickly. And then following after, you check the back and the neck to look for any scar to suggest posterior instrumentation. If you got time, then you want to do a gait. Definitely most of the time you will start here. And then after that, you should offer to check for anal tone and also palpate for neurogenic bladder. if you're thinking this is like myelopathy, and if this is a flaccid, if this is a flaccid paraparesis, then perhaps, like I mentioned, I will start from the bottom. I'll check for any calf hypertrophy, finger grip for myotonia, scapular vein, bulbar, face, eye, and then endocrine screening and also rash. Okay. If everything also normal, but patient just have pure proximal myopathy, then possibly this is polymyositis and or LGMD that don't have any additional sign. Okay. So next thing is the unsteadiness in walking. So the stem is unsteadiness in walking. Therefore, it's important for us to examine the gait. So when examine the gait, you need to know whether this is a pyramidal or extra pyramidal. If it's a pyramidal, it can be upper motor neuron or lower motor neuron. Pyramidal basically means that upper motor neuron, you will expect there's some hemiplegic gait when patient walk, or lower motor neuron, you will expect to see there is a high steppage gait or even vaulting gait when patient want to stand up at the same time and walk. You will realize that the patient will sway here and there. And if not, cerebellar gait, patient will be broad-based. Parkinson gait, usually they will have, sometimes if the patient forgot to take Matopa, the patient's supposed to forget to take Matopa, supposed to miss their Matopa dose when they come for exam, but let's say they accidentally take it, then perhaps the only sign that you can appreciate when you ask the patient to walk is the reduced arm swing. Other than that, you have to distract the patient to elicit the distraction. Then you will realize that it's a bit of resting tremor, a bit of rigidity. Then it's very difficult. Okay, but it can come out. So the next thing is sensory ataxia, in which how to differentiate between cerebral ataxia. You should do a rhomboid. You should do a tendon. Generally not useful. Generally, tendon gait sensory ataxia cannot perform. Cerebral ataxia can perform, but in a very severe cerebral patient, cerebral lesion also cannot perform tendon gait. So to me, it's not very useful. But the rhomboid is the one that you really need to quantify. In a cerebellar sign, in a pure cerebellar sign, rhomboid should be negative, in which patient should able to balance themselves, okay, when they do the rhomboid, okay. Sensory ataxia, they cannot. So what happened is that cerebral ataxia, when they put their feet together, they will already lost the balance. Okay, this is called rhomboid negative. But rhomboid positive means to say that they can balance themselves because it's compensated by their vision as well as their hearing, the vestibular part. So the component, when the third component, which is the sensory component, the perception one, is lost. So the moment they close their eye, then the only thing to balance themselves is the cerebellum lah, because the proprioception and the eye is gone. Okay, so if these two is gone, definitely the patient cannot balance themselves. Therefore, they will fall, they will unsteady, and therefore the rhomboid will become positive. That's how we remember. I remember this is how Shanti DP taught us before when we are in HKL. She mentioned to me that the balancing needs three things. One is cerebellum, one is your proprioception, your dorsal column, and the third one is your vision. Okay, if two of these three cannot work, then you will lose the balance. Okay, this is the principle. So okay, to cut the story short, so after you examine the patient gait, you need to know what are the things that you find. If you cannot find cerebellar Parkinson, you just proceed with lower limb. Basically, again, if a lower limb examine there is rigidity, you should proceed with the Parkinson, or else facet, you just continue. Power, continue to assess, reflex sensation, coordination as usual lah. Okay. So Parkinson, I have listed out here. If you want to hear in detail, you can also listen to the previous recording. But this is just a general approach how we perform a Parkinsonism examination. If you encounter a Parkinson patient, you should score a full mark because it's a template. Every marking scheme is all here. Okay, you should follow everything one by one. But you can omit this apraxia thing. We generally don't do that to look for. We write O to look for this constructional apraxia for a patient like cortical basal degen because it's so rare. We don't need to do. So we just need to do up face after we check the what we call as the crack, right? Tremor, rigidity, akinesia. And then after that, you also want to check the scar, abdomen, and then you want to end the examination by offer all these things, okay? And then this is how you present the Parkinson in terms of investigation and management. And next is the cerebellum. How you check for cerebella is usually we start with gait, you notice abnormality already. So you proceed with the head first, check for nystagmus, titubation, scanning, staccato speech. How to assess a speech is for Parkinson as well. It's very simple. You can ask patient to do is, can you name from December to January one by one? So patient will tell you like December, November, October. So you will able to elicit the speech, okay? And The other way is actually you want to do a shorter version. Perhaps you ask to do a Western registry or even like British Constitution, things like that lah. But it's actually short. Sometimes you're not able to elicit. You want the patient to tell, like for example, can you tell me your home address in full? Then you will sekaligus know whether patient have any scanning or staccato or even monotonous speech. After you check the head, you should go to the upper limb, check for pulmonary drift. Pulmonary drift will tell you whether that is a prenatal sign. If present, that is a prenatal sign. And the next thing is a reflex. You want to check whether the patient has hyperreflexia. So rebound phenomenon also you want to check and dysmetria and dysdiadochokinesia. Lower limb you want to check for any scar, walking aid. Okay, and then pyramidal sign basically you want to check for whether there's any like what I mentioned now. Lower limb basically you want to check for the tanta and the cronus because if present definitely this is a pyramidal sign. So how we divide is if it's a unilateral cerebellar sign, it's not much of importance to know pyramidal or non-pyramidal because the cause can be just isolated cerebellar lesion or combined. If it's isolated, then you are dealing with cerebellar sign per se. The cause can be due to SOL lah, space or combined lesion. But if it's the combined, then combined with the pontine lesion, then it can be due to CP angle lesion, okay? Or it can be due to lateral medullary lesion. Therefore, the cranial nerve comes into the picture. If it's a unilateral cerebellar sign, you should examine the cranial nerve. Okay, you can see that if you don't examine the cranial, you miss all these three together. You will just get the cerebellum only, isolated cerebellum, but you haven't exclude other cranial nerve pathology. These are all combined. Imagination, you should expect some form of optic neuritis kind of thing. You should expect RIPD, nystagmus. You should expect like INO. Okay, so we should examine the cranial nerve if you are dealing with unilateral cerebellar syndrome. But bilateral, your focus will be confirming all the cerebellar sign and focusing to check for any evidence of pyramidal upper motor neuron involvement. If bilateral cerebral lesion with pyramidal sign, your cause will be hereditary ataxia, which is like autosomal dominant ataxia in spinal cerebellar ataxia, or autosomal recessive ataxia like Friedreich ataxia or ataxic telangiectasia. It can also be due to demyelination like MS, MMOSD. And the rarer one, if patient is very old, you may want to offer a differential of MSA. Okay, so if it's a non-pyramidal, then the causes will be a lot. You can just spam everything. The commonest will be like, drugs, like phenytoin, carbamazepine, or alcohol being the commonest. And then the other thing like hypothyroid, Wilson, like metabolic causes, or even paraneoplastic one. And the fourth one perhaps I want to mention is the hereditary causes like von Hippel-Lindau or NF. Usually they will have some bilateral cerebellar hemangioma or hemangioblastoma, all those kind of lesions. Okay, but basically the important one is the first three. Okay, this is how you classify cerebellar syndrome. Okay, and peripheral neuropathy generally is pure motor or so-called predominant motor and then predominant sensory. So we need to divide into these two and offer the differential diagnosis accordingly. Okay, and generally the way I'd like to classify the sensory predominant, Prof. Raymond used to teach us about A to E, right? A to F or A to E, A, B, C, D, F. Alcohol being the first one, but I feel ABCD very difficult to recall in exam. Therefore, I still prefer to go by class, go by the commonest one. Sensory predominant peripheral neuropathy, I would put the metabolic one because diabetic tends to be the first one, and then vitamin B12, CKD, uremia, hypothyroid. These are all metabolic, followed by the drugs or toxin, alcohol. Because imagine it will be seems intimidating if we mention the commonest, the first cause of a peripheral neuropathy sensory predominant. If the patient is a Malay, then it will not be nice for us to mention alcohol as the first, right? Because we cannot assume people take alcohol. So therefore, I think metabolic should be the commonest and the first one to present, followed by the drug or toxin like alcohol, isoniazid, or even like chemotherapy or even RBD medication. Then neoplastic can be paraproteinemia like myeloma, or even can be paraneoplastic causes. Inflammatory can be CIDP, CMP, CTD, vasculitis. Infective can be this, infiltrative. So I tend to remember like, how I remember already, MMD. I cannot remember how I remember it, but basically I go by metabolic, drugs, and then neoplastic, or even mitotic, something like MTM, metabolic, toxin, and mitotic. And then after that, I remember inflammatory, infiltrative, and also infective, something like that. Okay, you will develop your own approach to remember. Muscle can be proximal or distal. Distal is a bit simple. You are either dealing with dystrophia myotonica, inclusion body myositis, or inherited distal like Miyoshi or even Velander, very rare, but just mentioned as a differential. If you got distal, most of the time it's DM. If proximal, it can be these four possibility. It can be due to inflammatory like dermatomyositis or polymyositis. it can be due to endocrinopathy, it can be due to dystrophic. For neuro, the commonest is still the dystrophic part lah. X-linked related is the Duchenne or Becker's, limb girdle, dystrophia myotonica, FSHD, or even ocular pharyngeal myotonic muscular dystrophy. So you can see the how do we know which one? Can I ever know, right? That's why it's important for us to screen for, like, if you encounter proximal myopathy, proximal muscle weakness, and also facet in nature, you want to screen for pseudocuff hypertrophy to screen for this. You want to screen for dystrophia myotonica to screen for by doing a hand grip. You want to exclude the scapula, meaning to screen for facial scapular dystrophy, and you want to screen the eye, any ptosis, any facial nerve involvement to suggest oculopharyngeal muscular dystrophy, and the remaining one, like no rash, polymyositis, limb girdle, tends to be the last one lah. That's how I think we should try to offer to screen for the etiology. Okay, and the last one is perhaps the rare one, mitochondrial disease and the glycogen storage, but worth to mention if they ask. So foot drop, I will not mention. It's a bit tedious, and again, listen back to the previous recording. And therefore, this is almost the last slide already. I have listed out all these, how many? 1, 2, 4, 6, 8, 10. These are all actually got 11, all the 11 syndrome that we need to know before we go for neuro short case exam, because these are the very common and very basis favorite or even master favorite scenario that can come out in exam. And therefore, it's important for us to go through what you need to, what are the steps that you need to do, what are the things that you need to examine when you encounter each of them. Okay, with that, I think this is the last slide. We should really continue to practice, and remember to mind mapping on all these common cases. This is actually an open book exam, because these are all the expected cases that can come out in the exam. We know that this can come out. We know like adult polycystic kidney disease can come out. We know Charcot-Marie tooth can come out. We know all these things can come out. We already know. It's just that we need to mind map ourselves regarding the approach. To me, the most important thing is still approach. If you have a good approach, what kind of cases also you know what to do. Okay, and short case is the one that you should aim for perfection, because talking station like com skill or even like consultation sometimes can be tricky. If you cannot get a diagnosis, your marks will be deducted heavily. Therefore, your short case must be always almost perfect. I think my respi, abdo, and cardio was full marks, and then the neuro is the one that, because I know it's a bilateral cerebellar sign. I know the patient is actually got pyramidal sign, but I cannot examine finish. Therefore I was minus like 1 or 2 marks there, but not much of marks. But you can see that generally, if you prepare well for short case, you should aim for perfection. You should aim for full marks. Okay, and the idea is actually to expect the unexpected, knowing all the possibility that can come out in exam. But having said that, if you're not sure of something, don't commit, and then just mention that I'm not sure. However, with enough time, I will examine further, and have to admit our own limitation. And the last is actually we have to rest well before the exam. And the last of the last is actually the luck. Sometimes no matter how much we prepare, perhaps it's the examiner, perhaps it's the patient, perhaps it's the case, it's the one that will bring us down. But we prepare, like for example, like 98%, only let the luck take the another 2%. At least we still have higher chance to pass. Okay, so that will be it. So we will end our session today. Anyone have any question? If no question, we'll just end the session. It's quite tired already, almost 11 o'clock. Okay, let's just close the recording first.